ABG, etc., or ventilator graphics. When they give you, they can ask you about something like maneuvers, etc. Okay, so this is one station. The other station definitely would be imaging and data interpretation again. Here, more or less, it would be a radiology and your laboratory investigations. So you need to know certain radiology for sure. You need to know about your chest X-rays properly. You need to know about your CT and MRI of the brain. Okay, and then obviously there are certain conditions of the abdomen and thorax, like pulmonary embolism for thorax and abdominal aorta aneurysms, pyelonephritis, probably even pancreatitis. You should know these are the things where they are classical signs which are present, right? Those images would be given to you, and then you'll have to interpret. So that time they can ask certain CT scorings. Okay, if you have an SAH, probably they can ask you SAH grading, or if you have a pancreatitis, they can ask you CT severity index, etc. So that's how it will you routinely go about. And off lately, because we are routinely using in most of the centers, point of care devices are becoming more and more available. So tests like TEG and rotem you might have to go through again. Okay, so this is something that you have to revise. We have already discussed this in our theory classes. If you guys can read that for the data interpretation classes in the later period, it would be helpful. Okay, so this usually consists of station 2. Station 3, ACLS and hemodynamic monitoring. This is something that is very important, and most of the examiners will be very keen on how you answer the station. They will look at how safe you are and how attentive and how protocolized you are. So they will make sure that whether you are going through the protocol properly, algorithm is being approached at the right way. Okay, so make sure that you read your ACLS and brush up these things. Okay, so very carefully you need to know the drugs, the dosing properly. Okay, so if you make errors in this place, it might be a little tricky. Okay, they might think about scoring good for you. They'll not be happy, because it's a very focused exam and very focused station, right? So please make sure that daily you start with an algorithm, keep presenting daily, so that you are aware as to how to approach to it. The other thing in hemodynamic monitoring, they can ask anything from arterial lines, CVP waveforms, IABP, pacemaker, etc. Okay, we will be dealing with all of this in the classes which we have planned for you guys. So this is one station where you might be looking at that. Okay, drugs and equipments, sure shot. It's really difficult, for us to complete all the drugs, but we have got a lot of feedback from our on-site class, so we have tried and done something more positive in the online classes. But yes, it will be really difficult for us to teach all the drugs, but you are supposed to know the most common things which were being used in the ICU. Fluids, okay, that is one thing you have to know. Antibiotics, all the anesthetic drugs which we are using, obviously the inotropes. Okay, so these are the things that you need to know in and out. There will be a format in which you need to present, that I'll be discussing with you guys tomorrow. Okay, this is a station where you can score more. Okay, so always be attentive when you're reading about it, and make notes of yourself. Okay, probably pick one or two drugs every day, and read it and make notes. Okay, that format is enough, because in the end you cannot take a huge book or the phone and then look into all the drugs for revision. When you make notes of your own, probably it will be easier to revise on the last day. Okay, equipments, yes, you need to identify limitations, contraindications for that, and troubleshooting of those instruments, etc. That is what is anticipated, and the questions can be guided on how you answer the questions. The one most important station, which is very close to most of the intensives of late, is the USG and the POCUS station. This can either be clubbed with your radiology station, or this can be a separate station by itself. Please know the basic echo windows. Please know few protocols, okay, for the lung ultrasound, and as well as the shock protocols, etc. You need to know all of this. Okay, so this is something which is beyond doubt, that they will not think twice to score you less. Okay, so make sure that you are aware of these protocols and go in a systematic way. Okay, please revise. I think so you've read it earlier, But yeah, go through it again, and then it'll be easier for you guys. But basic things is what will be asked for you. Don't worry about some very high funda questions or few signs which you might have not heard. Don't get panicked at that point if they ask you some sign that probably you might have not heard or you forgot at that particular time. Don't worry, they would not hold you to that point, and they won't fail you. But definitely, if it is a very common sign like lung sliding, if you're not answering a pneumothorax along with the lung point, that might be something that they might hold you to. Okay, so these are the things that you need to be aware of when you're going to the station. So this is about the stations. After this, we have a viva session as well. In the viva, there is again four stations. It starts with thesis. Definitely, there will be two examiners or sometimes one examiner, depends on how the center wants to conduct it. They will ask you about your thesis. So be very clear about your objectives, okay, and know what is the statistical tool that you have used, what is the power of your study, what are the limitations of your study, and what is the outcome of your study. Don't go there and don't open your thesis to tell. You should be confident enough, bold enough to tell your study, because you have done it over a period of 2 or 3 years, right? So that is something that they are looking at. Okay, so always remember, questions on statistics can be asked either here or in critical appraisal. Okay, so no, start practicing your statistics again. I think so the YouTube video is still available, the class we have taken. You can go back and start revising your statistics from there from now onwards itself. Okay, otherwise it's really difficult to cover statistics as a separate session. Okay. Critical appraisal, I think so Dr. Srihari will take the class today, and then he'll let you know with certain examples as to how to present. When you're presenting the critical appraisal, what they usually give is they give a study to the candidate. They'll give at least 10 to 15 minutes time for the candidates to go through. Okay, see, I'm telling you 10 to 15 minutes. There have been instances where they might ask you at the end of 5 minutes also. But if you know what to look for in the study, you will be able to do well in the 5 to 10 minutes period. Okay, as soon as you get that, how to make note of the key points in the study. Okay, where to look for limitations, where to look for all the statistical tools, this is what you need to mark. Okay, and when you mark it, you'll have a fair idea as what is going on. And when you go inside, the questions will again be on what is the study on, what is your comments, what would you want to do. And one question they routinely ask is, at the end of this trial, would you want to implement this in your center? So that's not, that doesn't mean that you have to say that I will. They will ask you to substantiate, if yes why, if no why. Okay, that's what they're looking at. You're going for a consultant level examination. Okay, that is something that they're looking at. Are you a sane enough consultant, a safe enough consultant at that level of thinking that you can implement certain changes? Okay, that is what they're looking for. Communication and ethics, I think so this is one area where they can take you for a ride. Don't worry, don't get intimidated, and don't get scared either. They will intimidate you. They might create scenarios where they can harass you also. I mean, it can look like an harassment, like how you routinely things are happening in the country, we all know about it. So yes, they can go to a certain extent that you can get a very tough relative. So they are looking at how you communicate and how you diffuse the scenario. They look at how valid points you're raising. Okay, what are you going through? Are you going through in a safe pattern? Okay, so interprofessional counseling and family counseling is something that is very important. They will look at your basic communication skills here. Definitely breaking bad news, conflict resolution, theoretically we can talk a lot, but whether you're implementing this theory in your practice is what they're looking at. Okay, the fourth station is on audit, quality, and patient safety. Main thing is, majority of the places I have seen that they club it with critical appraisal and they finish it off. Sometimes they do keep it as a separate thing. When they do this, they're going to ask you questions about quality indicators in your hospital. Probably they will ask you if have done any audit in your course period. They might ask you questions about quality indicators, antimicrobial stewardship, etc. So this is what is expected in the fourth station. All of this station roughly consists of a half an hour period. Okay, so they have enough time to spend with you to analyze your knowledge and your approach to things. Definitely you'll not be able to give 100%. Don't expect. Sorry. Okay, this is the issue, I think so. We have Bhagishri, can we unmute them?
Done, sir.
Okay, I'm sorry. Sorry. Sorry, guys. Okay. So next, this is how the conduct is. Okay. So I briefed you guys about how the long cases and short cases would be, how the station vivas and the table vivas would be like. So what do the examiners expect out of the candidate? That is what we need to know, right? So in the long cases, present the case in a very clear format. Okay. So that is what is expected out of you. Please have a summary ready. Okay. Look at the critical care aspects more than a medicine aspect per se. Look at what is relevant in the critical care scenario and present those points clearly. Always it's really difficult for the examiner to look into a whole history, right? So they might you might start off presenting, and then they might stop you in between and tell, please summarize the history. So when they say that, please be very skillful, and give them a crisp summary. The way you summarize itself will create the first impression, because remember, when you start the exam, you start with the cases, and when you provide a crisp summary, they know that your basics are strong. So then they will have an understanding that they can move on to the examination, and then they can continue with the actual management of the case. This is one trick that you guys have to learn. Okay, so if you provide a very crisp history, that actually gives you a lot of leverage. Okay, and then the examiners will take you to the next step as soon as possible. But if you have been let to talk about history, even you are bored, the examiner gets bored. Okay, so try and get that first impression on the examiner, that you know your case well. Okay. Always, I told you earlier as well, be mindful of your surroundings. Always develop a rapport before you start. Look whether the patient is conscious. Sometimes you'll have conscious patients in the ICU. Introduce yourself to the patient, the attending nurse, etc. There have been instances wherein the examiners can talk to the nurse later on as well. They can get all the relevant things that they want from the nurse as well. They'll look at your hand hygiene practices, your communication skills, okay, your examination skills, and how you conclude. Okay, all of this is something they are very closely going to monitor. If they are not there at the time of examination, definitely they'll come around later, and I'll ask the nurse whether the candidate has done so and so things. Okay. Sometimes examination also, they can ask the patient themselves as to, has this been done to you? Okay. So follow the bedside etiquette, basic hand hygiene. Always do something called as an endobedogram. Okay, you actually stand at the end of the bed whenever you're given a case summary in a long case, right? You get alarmed with it. Sometimes you'll be like, what is happening? Before even you see the summary, when you reach the end of the bed, right, you can see the things around the patient. That itself will give you a vague idea as what is going on with the patient. If you see a patient on a ventilator with inotropes, okay, probably an RRT machine which is parked by the side, you will know that the patient is having a multisystem disorder, probably has ARDS, probably has acute kidney injury requiring RRT, etc. So this is the things that you need to look at. If you give this thought, you'll be almost fixated in your mind that, okay, I need to look at these particular pointers. Okay, whether the central line is in situ, where is it in situ, how many days has it been, what is the condition of the line today, what is the condition of the catheter today. So these are the things that gives you of more input as well. Okay, so these are small nuances that I'm trying to tell. It is not something that will be given in the books. It's something that will help you get your uh, you know things going in order. Okay, so this is something that I wanted to talk about. Nutrition chart is mostly missed. Okay, majorly all of us are so focused in our treatments that we forget nutrition as being most important. Okay, that is something. Please ask for the nutrition chart. Ask about the feed tolerance. Okay, and what type of feed is being given. Okay, sometimes they can just throw a googly. You'll be talking about ARDS, you'll be talking about RRT, and then suddenly the examiner will ask you about what is the nutrition giving, what is the thing that the patient is receiving, or what is the status. So that will totally derail your course, because firstly you would be getting a sudden a shock, and then things might take a turn there. Okay, so it's okay, sometimes you will get questions like this. When you get this, please uh, excuse yourself at the scenario. Okay, just tell that, okay, there will be a certain things that you might have missed. Okay, so you can tell, I'm sorry, I have not done this. Okay, but yes, if you miss the most important thing, that is not something good. Okay, so one or two smaller errors of omission can be okay, but gross omissions, I think so, would be detrimental. Okay, so that, be aware of all such things. Okay, so make sure your history is good. Look at what is the patient on. document all these things, look at the nutrition, look at all the relevant investigations, focus if possible, do it. Okay, whenever they ask you to give the diagnosis, so first impression you've created with history and examination, etc., when you're providing the diagnosis, also give them a clear diagnosis. At this time you have all the investigations. It's not like a medicine case in your MD exam, right, where you give your differential, I mean your differentials, and then you would tell that I'll do the investigations, I'll think about a diagnosis. No, here you have everything at your disposal. You can give them a diagnosis and also tell them that I'm keeping a list of differentials even though I have these. Okay, so always give a diagnosis and then tell them these are the list of differentials. Okay, uh, I told you earlier as well, I'm reiterating that point. Please write down all the findings. They will tell you, but nevertheless, please make sure of all the points whichever you are, examining or taking the history. Just write it in that sheet. Okay. Coming to short case, I told you it's very brief, very focused. So here also you might have to write one or two sentences about the case. Look at the examination. If it's per abdomen examination, look at all the things that is involved in the per abdomen examination. Okay, so just don't do a percussion and then forget auscultation altogether, and don't forget to. I mean, if the POCUS is available, you can definitely use the POCUS at that time as well. Okay, so I know, but don't just run in and do a POCUS for every patient. Just ask them, do your due diligence, do your initial evaluation, and then you can go about getting for a POCUS examination. Remember, you have only 15 minutes. Okay, just don't wait for someone to get the machine. All of that can take a little, logistical issues. So look at the history, look at your endobeddogram, then you have a vague idea of what is happening, and then go to the laboratory investigations. So when you have this thing sorted, right, you have the history, you have the findings with you, then you can corroborate with your labs, and then you can come to a diagnosis. That is a swift way of going through things so that you can arrive at a diagnosis. Okay, then definitely they will quiz you about your management. So cases, don't worry. Okay, remember one thing. Okay, this is a consultant level examination. You are expected to answer like one. Okay, don't give theoretical answers. Okay, a long thing. Just be answering to the point. If they ask a question about definition of ARDS, answer only about definition of ARDS. Okay, don't give extra knowledge. It's not required. Okay, summarize the data in a very structured format. Okay, don't haphazardly start off. Whenever they ask you to summarize a lab detail, don't start off with one thing and go on talking about, start with CBC, suddenly you go to LFT. It shouldn't be in a haphazard way. If you're starting with the CBC, what are you looking at in the CBC pertaining to the case? Okay, so that is something that you have to talk about in a very structured manner. Okay, and how is it relevant to the case? Always corroborate your data to the case. Okay, that is very important. Bedside etiquette, I've been stressing this is something that they are very particular about. Hand hygiene, probably one, or most of us are actually worried about the evidence, right? They won't take you, they might not fail you just because you don't know an evidence fully. But yeah, landmark trials you need to know, major evidences you need to know. Okay, like surviving sepsis guidelines, you have to know it. Major trials in ARDS, you need to know it. Okay, so anything which is intervention based and which is given as level 1 evidence, that is something that you need to know. So these things, if at all it is pertaining to your case, that is something that you need to answer, and then they'll be happy to give you more points and probably get a better score. Okay, always remember one thing. If you are not knowing something, don't bluff. Okay, if you want to do an educated guess, you tell, I'm not sure, but I based on these things, I'm taking a guess. But never try to bluff. Okay, that is something which the examiners do not like. It's just like you're digging your own grave, and then you'll go into a vicious spiral. Okay, so try and avoid that as much as possible. Okay, I will just say, try and just omit it. If you don't know something, please tell, I'm not aware of it. Okay, stations and viva, it's again a time dependent thing. 30 minutes odd is the time point. Okay, so you will be given many options. Okay, if you have certain thing or an instrument you might not know fully, try and answer as much as possible. If you're not knowing, just go on to the next one. They will definitely move on to the next drug, okay, drug or the instrument or so on, okay. One thing you remember, if you've not felt that you have done up to the mark, it's your perception again, because you still don't know what is the overall outcome. If you feel that you haven't answered one or two questions, don't worry, it is not going to matter that you are going to fail because you didn't answer one or two questions, okay. Definitely, I told you the cumulative marks is what matters, and in the end it depends on that, okay. So don't carry whatever happened in the cases to the stations, okay. That is something that you need to leave it in the cases. In the afternoon, go back with the same amount of confidence and rigor and zeal that you'll do well, okay. So probably you might score better in these stations, and in the overall outcome, if it matters, that you might do even better than what you did in cases, okay. Always listen to the examiner, listen very carefully of what they are asking, okay. So few examiner, it's most of the times it depends on how the examiner is, okay. So you need to look how they are asking, what, whether they want you to take a guess, etc, okay. So few of them would not like you to use unnecessary words, okay. So they would be listening that looking for a particular answer in a particular format. If this, you would know by the time you come to stations, so answer it the way the examiner wants, okay. It's not, I'm not telling you to impress them, but at least not piss them off, okay. Don't make them angry. Communication station, use your soft skills up to the mark. The only thing they're looking at is how you are able to diffuse the session, okay. They're not looking at their overall outcome, and don't worry, they're not, nothing will matter at the end of the day. It is a mock drill which is going on there, okay. So don't get scared, don't get worried, okay. But don't cause any mishaps, okay. Don't promise some person that you're going to give them some remuneration, etc, okay. No, nothing like that. Always make sure that you give a midway, okay. Own up to a few certain mistakes, that is always told in conflict resolution, probably, yes, okay. But yes, don't expose your staff, okay. Then answer in a way that does not offend the person as well, okay. So you focus on your spikes protocol for breaking bad news, etc. So you have that thing fixed when you're answering. That is something that you have to do it on a day-to-day basis. So start presenting on a daily basis. Especially communication is, you speak to your seniors or whoever is there, present cases, and then ask them to give you examples of case scenarios, and then you can brush up your soft skills, okay. This is more or less about how to prepare for the exam. Rest, this is something that most of the examiners felt, and there's a few feedbacks that we got. They also look at how you are coming to the exams, so please reach the center earlier. Don't go there sweating, huffing and puffing, okay. So don't go breathless on the time of examination, and as soon as you enter that you are breathless, and you're just trying to get acclimatized. Go to the center early, a day prior. Get used to the surroundings. I've said this in the on-site class as well, okay. Be accustomed to your center earlier itself. Even in the center, go find out which floor, whatever it is, because most of the centers are in big corporate hospitals, so you need to know your center in and out, okay. So that you don't have that worry that next day where is it, where to go, and all this confusions on the early morning of the exam, that will be offset, okay. So please present yourself in a good way. I mean, formals, that is going without any say. Don't forget to take your thesis. Don't forget to take all the documents of the exam. Okay, that is something that you have to not forget, and there's no excuse for it. If at all they ask you to give your thesis, you may have to definitely show thesis and logbook. Please carry with you. Okay. Uh, Rest of the things, I think so. It's quite the similar one which you do for any exams that you prepare for. Rest as much as possible. I know it is difficult. It's very easy to say right now, but yeah, it will be a little haunting day prior to the examination. I know a lot of stake will be there for that exam. That just one step away from your degree. So yeah, keep it as cool as possible. You have done well all these ways. You have cleared your theory. That itself is a reassurance that you guys are good, okay. Just keep that going, okay. Avoid carrying books to the exam center as much as possible. It's easy to say, Okay, even I have carried, I hold myself guilty for that. But yeah, in the end I realized that I didn't open the book. So we don't have time. As much as possible, if you're having one or two sheets that you want to brush through, some cheat sheets or something like that, you can take it. Books unnecessarily, I think so, we don't have time. Frankly speaking, I never got the time. So it's out of experience, I'm telling, please don't carry them. Okay. uh, Eat well, stay hydrated. Okay, that is very much necessary, especially given the fact that our exams are in, the summers, so that matters a lot. Okay, so unnecessarily falling sick on the day of exam actually can put down your efforts, which you have done for all this, while lot of sources are there. I'm not going to dwell about it. You guys already know because you have already prepared for your theory exams. Case based review, totally, you have all the cases provided there. Okay, finish it off. Critical care updates, if you guys have prepared during the theory, you brush up whatever you have read. Don't read anything new. Okay. uh, Internet book of critical care, evidence based practice, these are the things which I usually go through whenever I have some issues. Nature reviews has always been the savior. It is actually a good thing. Most of the diseases per se, like your GB syndrome or acute kidney injury or TTPHs, TTP and all, you can use the ISTH website. Okay, the hematology journal. They're all good sources for reviews. Okay, wherein you can have the overall picture of the disease and management. So a lot of resources are available. I don't say that you guys go and pick up all these right now and start off. If you have used them, well and good. Better not to do any new research. But case based review, I think so, you guys have used it for your exams, so stick to that as much as possible. Okay. Most importantly, the thing is, present it to your peers. Okay, whoever is there in your hospital. If no one is there, probably there are centers where the single candidate will be there. From a group amongst yourself, okay, whoever you're comfortable with. I was the first batch DRNB, so the only thing is we formed a group amongst ourselves in Bangalore, and we discussed among all of us. So one of us used to present and another one used to ask questions. We used to, have role plays of examiner examinee ourselves. That's how we actually came across, and then that's how we could understand things better. So it always helps. You form the group, don't waste time. It's your call. Eureka moment. As soon as the question to speak much on that. Okay. So on that note, always with this, I think so, I'll hand over the session to Dr. Srihari. I think so, because of all this confusion, we are short of 15 minutes. Okay. So all the best, guys. If you have any doubts regarding the pattern, please let us know. Okay. I don't think so it's such a rocket science, since you guys have already given your FAT exams. But just I thought it will be useful if I can give this update. So Srihari, good evening. Are you there?
Yeah, good evening, Darshan.
Hi, hi, hi. I
Uh,
think so. Everyone is waiting for your session right now.
So
So
I'll start sharing my slides.
yes, yes. I'm just stopping it. Yes, you can start off.
Is the slides visible?
Yes, yes, yes. It's visible, Srihari. I think so. You need to, yeah, enlarge
Okay.
it and then you can go. Good to go. Okay.
No, it's
Oh,
okay, right?
yeah, yeah. Great. I think
Okay, fine.
it's still. Can you enlarge it? I'm seeing it in tool window, presenter window actually.
Okay, 1 second.
Yeah.
Just a second. Now is it okay?
Yeah, this is good. Yeah, great.
Okay. Okay. So I'll start my discussion. So good evening to everyone, and congrats to everyone who have cleared the theory. I think that is one of the biggest barriers that you've cleared. So regarding critical care, if you have cleared your theory, usually the practicals is relatively easy to pass. because the pass rate relating to critical care is good compared to the other super specialties. So, without further delay, we'll go into my discussions. So, I'll be concentrating on critical appraisal of a research paper and I'll be talking about ECGs. So, for critical appraisal, I'll be concentrating on what is needed from a practical point of view. I'm not going to go in depth of how you really do it in real practice. That will not be applicable. But what is necessary for our exams is what I'm going to concentrate on. And for ECGs, it will be more like a one-to-one discussion so that it will be interactive and we'll be able to finish it faster and we'll also be able to gain more knowledge also. So, uh, just the basics related to critical appraisal of a research paper. Usually in the exam, they will give you this research paper about like 15 to 20 minutes after your long cases and short cases are over. So that is during the lunch break will be the actual time when you will get to prepare your prepare meaning you will be able to go through your research paper. So you need to be very focused on what all areas you need to cover. So the number one golden rule for a practical exam in relation to critical appraisal, please do not read the abstract in front of the examiner. That will create a really bad impression. And after that, he will not be very interested on asking further questions because the abstract is just like a summary. Like if you're looking through your Instagram, you're seeing through the reels, right? That they may show that reels for about 1 to 3 seconds, like a just like a snap view. So that is what the abstract is actually is about. What you really need to go through is from the introduction point of view. So that's where the main contents are, and that's where you need to really focus. So, rule 101 is please don't read the abstract in front of the examiner when you're starting a critical appraisal. So, the next thing is underline the significant findings and keep it in your view when you present to the examiner because you will already be thoroughly stressed out. So when you read through the research paper and you have all the points in your mind, you just keep it underlined so that when the examiner asks, you just point out and read those points which you have underlined alone. So those will be in a systematic manner so that you don't miss anything and it will also impress the examiner. So like Darshana told, in relation to critical care appraisal, the ultimate thing they will ask in the end is whether you will use it in your real life practice. So the way you have to identify that is by looking for any bias in the study. So the more number of biases that you can identify, the less valid it is going to be. So that kind of in that way you can say that you will not use it. For example, for me, I got prone ECMO study for my practicals. So I read through that. It was an open label study, and there were multiple flaws in it. So then towards the end, he had asked me whether you will implement it in your routine practice. I told no, I will not implement it. And I gave him the reasons like 1, 2, 3, 4, 5. So he was okay with it and he told good indeed. So that is what they will expect at the end. In case you say that you will use it for the in your practice, then you will have to justify your reasons for that. So that is what they will mainly expect. So we'll have a PPT discussion and then I will just show you one study like how to go through it so that we'll have a clarity about critical appraisal from a practical perspective. So the main areas I'll be covering is the introduction and analyzing a research paper. So why is critical appraisal important? So we'll just take a small example. So we have a doctor 1 to 3 who reads the latest latest issue of a journal. So he had read that in a randomized controlled trial on a new treatment had actually caught his eye. So the results showed that the new treatment was better than a placebo tablet, and it had helped patients to improve faster and with fewer side effects. So the authors of the article recommended the new treatment as a first-line intervention. So without a further thought, this doctor was convinced that his patients would benefit. The problem was he had just read the abstract without reading the inner contents of it. So he expected to achieve better outcomes than his colleagues, and with the next day itself, he started prescribing this new medication to his patients. So we'll come to the next part of the story towards the end, like once we read through the full topic. So the main areas we'll be covering is the concept of evidence-based medicine. Why do we need to critically analyze a study and the elements of a critical appraisal? So the concept of evidence-based medicine. So what is it? It's just a phrase that is used to describe the process of making clinical decisions about a patient's clinical state, considering three things. One is the best evidence that is available, then our clinical expertise and the patient preferences. So based on these three, the foundation for evidence-based medicine is made. So what are the components of it? There are 5 steps. One is the question, the evidence, the critical appraisal, the application, and the monitoring. So question is you formulate a precise structural clinical question about an aspect of patient management. Okay. So you, like example, you in septic shock, you just
Recording stopped.
Dear candidates, sorry for the interruption. I will call the faculty. Yes, sir. Now you are audible, sir.
okay. Sorry, I think there was some network issue, so it got cut. So
Okay,
I'll
sir.
just go back.
1 minute, sir.
Recording in progress.
Please start, sir.
Yeah. So, like I said, the concept of evidence-based medicine, you look into three things: the best available research evidence, the clinical expertise, and the patient preferences. So, the main steps of evidence-based medicine is question, evidence, critical appraisal, application, and monitoring. So, the question is you formulate a precise structural question about an aspect of patient management, like use of steroids in sepsis or septic shock. Then you gather the evidence around it. Then you critically appraise it. That is, you look into the study, like you look into the adrenal study, and you see the results, and you apply that intervention of that study to your patients and see. And then you assess whether it is having the same effectiveness as what it had for the patients. So this is the actual concept of evidence-based medicine. But what is important for us is to look into the critical appraisal part of it. That is more important for us, for our practice. So what we need to do is evaluate the evidence, critically analyze the evidence for its validity, impact, and applicability. So this is what we need to look into. So what is the main definition of appraisal? The act of assessing something or someone. So why do we need to critically analyze the study? Number one, to detect bias and to understand the systematic magnitude of the study, to assess whether knowledge study can be applied to patients. Because study is going to be full of errors. It is going to realistic results. It is result for your purpose. So then that the study has been
Sir,
shown to be
sorry
like
for the
example.
interruption. Excuse me, sir.
Yes.
Your voice is breaking
Yes.
in between, sir.
Oh, is it one thing? I'll just see.
Please check once your network connection, sir.
Yeah.
Recording stopped.
For the bad networks. So just to go through again, why do we need to bias? So
Recording stopped.
Sorry, sir. Your voice is again breaking, sir.
One second. Okay, now is the screen clear and my voice audible right now?
Yes, sir, you are audible now, sir.
Okay. So far, there is no break, right?
Recording in progress.
Okay. So really, sorry. So we will go back into the discussion. So why do we need to critically analyze a study is one, to detect bias and error, because that will cause a interruption in your internal validity. So that I'll be discussing subsequently, and to understand the significance and magnitude of the study, and to assess whether the knowledge from the study can be applied to your patients. So what are the 5 elements of a critical appraisal? The first thing is, what is the research question? What is the design of the study? Assess the study's applicability. So these are the main areas that you need to look into. So how you can do that? The first thing is, in the exam, if at all you're going to look into the research paper, always look into your PICO. That is the population, the intervention, the comparison, and the outcome. So usually these details will be present after the introduction paragraph. So once you do this itself, you will be able to organize the first part of your appraisal. The other thing that you need to keep in mind is, for outcome, there will always be a primary outcome and secondary outcome. So it is important to look into both of them. For example, in most of the steroid trials in septic shock, they would have always mentioned the primary outcome in relation to mortality. But the secondary outcome will be in relation to resolution of vasopressors. That will be very much significant. So those details you need to mention in your being asked. So it is very important to look for what the outcomes are and if it will be relevant to your practice, that is your generalized applicability. So what is the study of the design? So for the exam, most of the time, RCTs only will be kept. The rest of the types of studies will not be there. It will be more of RCTs only. So you need to concentrate more on those areas. So if at all they ask you about the level of evidence, the best evidence, as you all know, is for systemic reviews and meta-analysis, and the poorest is for editorials and expert opinions. So why this is important is, at the top of the pyramid, the risk of bias is very, very low. Whereas at the bottom, the risk of bias is the highest. So RCTs come at the second. So that is why if it is a well-conducted study, usually the risk of bias is less. So you need to look into how the study has been done, whether there is bias. That is what I really want to emphasize. So when you look into the research paper, keep looking for any mistakes that have been done or something that is being out of protocol. So that you can mention to the examiner and that will add value to your marks. So coming to say, higher the quality of evidence and lower the risk of bias, better the validity and applicability of the study to the general population. So the best study depends on the type of question. This is just for general knowledge. So for assessment of which therapy is better, generally a randomized control trial is ideal. For a diagnostic test assessment, usually a prospective cohort would be ideal. But for, again, like I said, for an RCT, RCTs are usually the ones that will be asked in the exams. So like I said, a poorly conducted study usually tends to overestimate the effect of an intervention. So assess the study's validity. That's the next part of it. So you look into the research question, then you look into the study's validity. Was the study conducted so that the results are true for the sample that was studied? So the main thing you need to look over here is for searching for bias. So bias, most of you would know about it. They are mistakes that don't occur because of chance, but due to mistakes in the research study. So it leads to erroneous conclusions as a result of differences between groups that are simply not due to chance or exposure of interest. So when interventions are applied based on these conclusions, it can lead to harming patients. So that is why it is very important to critically appraise it, because based on the data that is being provided, if it is not properly assessed and if there are a lot of mistakes in it, ultimately your patients may be harmed. So like I said, bias overestimates the effects. So when you critically analyze a paper, always and always look for bias. That is your one of the primary goals that you need to do. So types of bias and the ways it can be avoided.
Sir,
So
you are
the
not audible,
first
sir.
one is sampling bias or a selection bias. So that will voluntary taken taking a drug.
Sir, can you repeat this slide because your voice is not audible?
Okay.
Okay, sir.
The previous slides I was audible, right? It's only this slide or the previous slides
From
also?
this slide only, sir.
Okay, fine. So coming to the types of bias, the first type of bias that we need to know is the sampling bias or the selection bias. So it is caused by non-randomization, leading to biased selection of participants for a study. Example, volunteering subjects may not represent the study population. Example, if you are taking studies for like a drug study and you take healthy volunteers, that may not represent the true population of those who actually may need that drug for their purpose. Example, you have found a new oral oral hypoglycemic agent for diabetes. The problem is initial volunteers who come for it may be normal subjects. So if you give it to them and you expect a response, that cannot be applied to the general population. So that is what is they have emphasized over here. So the important thing is randomization is important. So if you see a study and you see that it is not randomized, you can be well assured that there is going to be a high chance of bias in that study, and the internal validity is going to be very much affected. So it is usually seen with case control studies and retrospective cohort studies, all the studies that go in a backward manner. And sampling bias can be avoided just by randomization. So there are 4 types of randomization. In that, stratified random sampling is considered the best form of randomization. So if you have a study that has this kind of randomization that is done, then you can be well assured that the randomization is good. So the conclusion of the slide is you check if the study has been randomized. If it is not, then there is an increased risk of bias. So coming to the second bias that can be that is called the recall bias. So it's a systemic error that can occur when participants don't recall previous events or omit details. So the problem here is there may be studies where you would have recruited a lot of patients and the timeline of the study may be very significantly high. So the problem is you may have able to elicit most of them proper. Just once the enrollment has been done, you as quick as possible. In most of your neuro-related trials, they would have used the modified Rankin scale as a marker of neurological outcomes. That is a good objective tool. So if you see in most of the studies, they will be using modified Rankin as their main objective score to assess neurological outcome either at 6 months or 3 months. And accordingly, they interpret the final results. So the conclusion to this slide is if the subjective measures are used rather than objective measures, or there is an increased timeline between the data collection and enrollment, then there is a very, very high risk of bias that can occur. So we have seen about sampling bias and we've seen about recall bias. So sampling bias can be avoided by the use of randomization, and recall bias can be avoided by decreasing the time period between the sample enrollment and data collection and using objective tests. So in the study itself, most of the places they would have mentioned about the objective tools that they have used for assessing the outcomes. So the next one is observer or Hawthorne bias. So usually in most of the ICU patients, most of them would be intubated. So this would not be much of a problem. But in other scenarios, there may be instances where the patient may change his behavior when he is being observed by a interventionalist. So when they change their behavior, it will provide a different perspective to your data. So that may create a bias. The best example, what they say is like when you're sitting in a classroom, when there is no one to supervise, our behavior will be totally different. But when there is a teacher or a senior person who comes into the class and who keeps observing you, your mannerisms totally change. So that change may create a total change in the effect of your data. So that is called as Hawthorne bias. The importance is it may threaten the generalizability to the general population, because at that moment of time when they change their behavior or change their attitude, the data that is being collected is going to be different. So that may not be representative of the true population. So that can be avoided by single blinding. So if at all you're able to do a single blinding, you can avoid this observer or Hawthorne bias. So the next thing is, in conclusion, is check if single blinding has been done in your study protocol. If not, again, there is an increased risk of bias. Then you look for interviewer or expectancy bias. So occurs when the physician knows which patients are in the treatment and the control group. So that will give an impression to the physician to draw results based on the intervention that is being applied. So if at all they feel that they have read about some retrospective studies showing that steroids have been very beneficial in septic shock, and now a randomized trial is being conducted and he's aware of it, he may be favoring the use of steroids in those subset of patients. So that itself can lead to a possible bias. So that can be avoided by double blinding. So the conclusion here is you check if double blinding has been done. If it is not done, then it can be associated with an increased risk of bias. So the next one is proficiency or intervention bias. That is, there can be an issue when intervention is not uniformly performed to all the study subjects due to a difference in skill, training, and resources, leading to different inferences in different participants. The best example is now a lot of studies are being done on VEXIS and renal resistive index. So to get a proper Doppler view of the arcuate arteries and veins, you need expertise. So if one person alone keeps doing it regularly and he is being appointed in the study to perform it, the results will be uniform and it will produce good outcomes in relation to your study. But if you make 10 people do the same thing and all 10 people don't have the same level of expertise, each one is going to produce a different kind of result. And that is going to affect your overall outcome. So that is what is meant by proficiency or intervention bias. So that can be avoided by performing a pilot study first. So you evaluate if different people can produce the similar results, and based on that, you can then plan your main study. So always in your research paper that is provided, you assess if there is a pilot study that has been done previously, and if the interventional group has very few number of people who perform the study. If that is so, then it is going to be a good validity. If not, if there is no previous pilot study that was done, or there are multiple people who are being performing this, then there is a very high risk of bias that can occur. Then transfer bias. There can be unequal loss of follow-up between cases and controls, and exclusion or attrition bias that can be seen in per protocol analysis. So the main thing over here I want to emphasize is you need to know whether the study has mentioned about intention to treat analysis or per protocol analysis. So I think most of you know what is intention to treat analysis. You have 100 patients who have been randomized, and you assess the effect of an intervention in those 100 patients. So you see that among those patients, a few patients have lost to follow up. In intention to treat analysis, the people who have been studied and the people who have lost to follow up will be included, because that will be representative of a real life scenario, because that is what happens even in our ICUs on a regular basis. Whereas in poor protocol analysis, the problem is once you've randomized and there are patients who have lost to follow up, that is, example, like a 20-day mortality following use of steroids and septic shock, the patient might have been discharged after 14 days from your ICU or from the hospital. The next 14 days, if they have not responded to you or you're not able to reach them, those subset of patients will be excluded from your poor protocol analysis. So that will lead to an exclusion, possibility of an exclusion bias. So you always need to see in the study whether intention to treat analysis is mentioned or poor protocol analysis is mentioned. If intention to treat analysis is present, it is representative of your generalized population or generalized care, what is routinely seen. So that is a better choice than poor protocol analysis. So are the slides visible so far? I just wanted to just confirm it once.
Yes, sir, visible, sir.
Okay. So there is no break in the voice so far, right?
No, sir.
Okay. So among all that I had spoken so far, I'm just going to summarize all of this. So this is just for a good remembrance. So you can divide the study into two parts. One is the study design and during the clinical trial. So during the study design, there is a possibility of sampling or selection bias that can be avoided by randomization. And I had specifically told you go with stratified random sampling, that is considered the best. If you ask if there is a second best or there's something little that is little inferior, but it's still okay, is block randomization. Then you have bias during the clinical trial. Like I said, you can have observer bias that can be avoided by use of single blinding, interviewer bias that can be avoided by double blinding, recall bias that can be avoided by use of objective measures, interventional bias that can be avoided by use of a pilot study and keeping minimal number of people performing the intervention. And for exclusion bias, always look if intention to treat analysis has been done. And for transfer bias, assess for homogeneity in the distribution between the cases and the controls. So if you see that, especially in crossover trials, sometimes when you are related to your ECMO trial, the number of patients in the intervention group than the control group, that itself can lead to a possible bias. So I think hopefully everyone would have understood about it. So these, if you want, you can take a snapshot of it. These are the main areas you need to look into the study from a bias perspective. So if you find any of these are there, then that is going to affect your internal validity to a great extent. So you've assessed for bias or error. So the next thing is you assess the study results. So you can divide it into two parts. One is the descriptive statistics and the inferential statistics. So the descriptive statistics are related to those who are in the study, and the comparative statistics are how the groups were compared. That is the tables that were used or any kind of charts that were used, the standard deviations, the p-values, the confidence intervals. And if number needed to treat is mentioned in your study, please emphasize them as much as possible, because it's a very important terminology and it has a lot of clinical significance.
So you're
Yeah,
not.
so p value not audible. Now is it okay? Or
Yes, sir. Is it okay, sir? But previous slide, na, from last onwards, you are not audible, sir.
Okay, I'll just repeat that again then. So you have descriptive statistics and comparative statistics. So descriptive, I've told, those who are in the study will be considered. Whereas in comparative, you will be assessing the tables and graphs, the standard deviations, the confidence intervals, the p-value, and you will also be assessing the people who come under the number needed to treat. So if your study has number needed to treat mentioned, please emphasize it as much as possible to your examiner, because it's a very, very important number and it has a lot of clinical and research related significance. So p-value, as you all know, it shows only statistical significance. It does not have any clinical significance. So that needs to be very much kept in mind. So example, in a data set, there may be statistical significant association between patients whose name starts with the letter A and death due to myocardial infarction. But that does not have any clinical significance. So that is the importance of what I just wanted to say. So the next thing is related to standard deviation. So under standard deviation, you need to know what is mean, variance, and standard deviation. So I'm just going through these just to refresh your memory. So mean is just the sum of all values by the total number of values. So variance shows the dispersion of values around the mean. So assume that the mean is in the middle, all the values that are associated will be dispersed around it. So standard deviation explains how much the values are scattered around the mean. So variance just shows the values are around the mean, but the standard deviation explains how much. So that gives better quantification. So it's, as you all know, it's just the square root of variance. And why is it important is you have a bell-shaped curve for the assessing the distribution of data. So that extent of that bell-shaped curve is dependent on your standard deviation. The greater the standard deviation, that is, you have 1 standard deviation, 2 standard deviation, and 3 standard deviation, the more higher, the greater the spread. So I think all of you are aware of this diagram. So this is during a normal distribution. Usually what we check is for 2 standard deviations. That is, at least the data that we have collected will be within 95% of the standard deviations that are being assessed for. So why this is important is for this, the confidence intervals. So just brushing through this, it is range of values which most likely to contain the population parameter like a mean. So it is expressed as a percentage, like 66%, 95%, 99%, etc. So the percentage is related to how much the probability that the mean obtained from the study is likely to be the real mean. That is, within that distribution, the mean is going to be present. That is, it is not going to be in that 5% that is being left out. So that is where the confidence intervals play a role. So for example, a 95% confidence interval is a range of values that you can be 95% certain to contain the real mean of the population. I hope everyone had an idea about this. Okay. So as the sample size increases, the range will narrow and the precision increases. So the conclusion is, the smaller the confidence intervals, the better the precision and better the internal validity. So you have a higher sample size, the confidence limits comes down and the precision improves. So this is the main conclusion I want you guys to keep in mind. So you interpret it. So when you compare 2 groups, if the confidence intervals do not overlap, then that is equivalent to a significant result. Whereas if they overlap, then there is a insignificance. So the next question that can be possibly asked, especially if it is
Sorry,
related to
sir,
it.
your voice is again breaking.
Okay.
From this slide.
Okay. For the previous slide, or is it previous slide?
Sir.
Is it? Okay. So for interpreting the confidence interval, now is it okay?
Yes, sir.
Okay. So when interpreting 2 groups, if the confidence intervals do not overlap, then that is equivalent equivalent to a significant result. Conversely, if they overlap, then it is considered as insignificant. That is almost equivalent to a p-value more than 0.05. So the next thing is to assess which is better, whether a p-value is better or a confidence interval is better. Both can indicate statistical significance, but the p-value just tells you whether it is significant or insignificant. That's all. Whether it is 0.04 or 0.001, it won't make much of a difference. But the confidence interval can indicate the magnitude of an effect and the clinical implications that can be there because of the range of difference that can occur because of this difference. So, more easier to say, p-value just tells yes or no, like a binary. Whereas confidence interval can quantify the significance of the difference. I hope that makes it very clear. So this is very, very important. And this is one thing you really need to keep in mind. So the number needed to treat. So the number needed to treat is the number of patient to have a positive outcome. So this will be invariably asked. So I personally would recommend everyone to remember the definition. So NNT is the number of patients you need to treat for an additional patient to have a positive outcome. It is a useful way to summarize the clinical effectiveness of a treatment assessed by binary outcomes, that is yes or no. So there is no specific cutoff value for an NNT. The basic formula is 1 by absolute risk ratio. But what they say is the lesser the number needed to treat, the more effective the treatment. That is, if the number needed to treat is 1 or 2, they say that the intervention is going to be very, very effective. Whereas if it is around 100 or 150 or so, then it is very less likely that the intervention is going to be effective. So that needs to be kept in mind. So the next thing is you assess the study's applicability. Just being good enough to answer the clinical question. That is also called as the internal validity. So if the study has a poor internal validity, we may have unrealistic expectations of the outcomes. So this is what I had emphasized. You always need to assess whether randomization has been done, whether adequate blinding, whether it is ideally a triple blinding is the best thing, but at least if double blinding has been done, it is important. You assess for proficiency bias, any other form of issues that can be there, any exclusion bias that is there. So all these need to be looked into, and you also need to look into the whether the division of splitting of samples between the intervention and the controls are almost equal or equivalent, so that there is no transfer bias. So all these need to be kept in mind. So if you find there is any disparity in any of this, there is a high chance that the internal validity is going to be affected, and because of that, the overall outcomes is going to be very much spurious, meaning it's going to be false data. And to what extent can the results from the study be generalized to a wider population? That is called the external validity. So we want to know whether we will get the same results if it is used in a real life setting. So example, there have been studies in CLD patients where you use 20% or 25% albumin, and it has shown to help in reducing mortality. But if you see the subset of patients, it is related exclusively to patients with CLD. You cannot be using that for all other patients because the results are not going to be the same. So that is what is meant by the external validity. So when you read the study population is very important. That's why you need to look into PICO. So when you look in the population itself, you will have an idea which subset of patients they are reading about. So in most scenarios, it will be similar to the ones we are also seeing. So it won't be much of a problem. But there may be certain instances where they may predominantly look into oncological patients or patients with cirrhosis. So those subset of patients, when they use an intervention, that cannot be generalized towards other subset of patients. So that is what needs to be kept in mind. So what I really wanted to say is, do the subjects studied look like my patients whom I routinely see, and does the outcome really matter? So just coming to the first question, small story that I had spoken about. So the randomized trial caught the physician's eye. So he wanted to use that intervention for his patients because they had told that it was recommended as a first line intervention, but he had only read the abstract. So he began to use it on all his patients. But 1 month later, he was called to the office of the medical director, and they found that the analysis of prescribing costs in his department were very high than his colleagues, and it did not show any good results. So, looking into the study, the medical director had identified various pitfalls in the study that did not reciprocate into real life scenarios. So, following which he was told to abandon the medication he was using for his patients. So I think this story might give you an understanding of why it is important to critically analyze the paper. So you always need to look into biases. You always need to look into the distribution of data, whether the statistical significance has been appropriately done. And you always need to assess the external validity, whether it can be applied to your subset of patients. So this is the gist of what I had told. And from an exam perspective, this is what is needed. First is that the PICO format. If you have a T, it also needs to be applied. That is population, intervention, comparison, and outcome. And along with that, the time frame of the study. So that also, if it is applicable, that needs to be mentioned. And the factors that need to be looked into, that is the allocation, that the randomization that has been done, if preferably stratified, if not, at least block randomization should be there. Then assess if blinding is done. Ideally, a double blind study needs to be done. Triple blind, way better. But if no blinding is being done, you need to be very, very cautious about implementing it in your real life scenarios. Then follow-up of patients. Because exclusion bias is high likely, always assess the intention to treat analysis has been mentioned. And in the algorithm flowchart about the distribution of cases, the intervention and the control group, always assess whether the distribution of the caseload in both the groups are almost equal. Because in some, there may be a lot of patients who might be excluded in the other group, there may be very few. So that may lead to a big bias when you do the final analysis. So that also needs to be kept in mind. The next is about the presentation of results, whether it is very precise and clear, whether the tables, the division of all the cases and controls are all equal for all populations, male, female, comorbidities, the severity of diseases that they have, etc. And whether you can apply it to your local population. So this thing needs to be kept in mind when you practice your critical appraisal. So this is the main slide I want all of you to look into. And the other slide is about the slide on bias. So these are the two slides I really need you guys to have it like a take-home message. So the next thing is about what must you know about your thesis work and how to prepare to answer anything related to your thesis. So I think most of you are already been primed about this, but from my side, I'll just say what is really needed. Number one, please memorize the title of your thesis, because the exam and that stress, you will like try to read the thesis heading from the book that is in front of the examiner. That will create a really bad impression, and then he will be tempted to ask more questions and decrease your morale. So the number one thing is always remember the title of your study. Second, the methodology of how you did your study, the statistical tests that you had done. These three things you need to keep it in your mind. So that is, these three areas are ones I'm really emphasizing, because having been a DRNB candidate like you guys, many of us are there who would have given our thesis to outsource you cannot imagine. So that is one. Second important thing is, after they have gone through your thesis, they have discussed about your methodology and statistical analysis, they will ask you specifically whether you are using the results of your study in your regular practice. Please say yes. Because if you say no, the next thing is they will ask is, then will you do your thesis? So if that comes, that will create a very sorry face. So irrespective of whether you are using this your thesis study in your regular practice or not, if they ask anything related to that, just give an affirmation that you are doing it. Example, my thesis were related to intradialytic hypotension scoring system. So it's not that I've been using it after the thesis got accepted, but from an exam perspective, since they had asked me, I told yes, I did do it. So then they were okay with it, and then they left me. So this is one area I think you guys think you can tell a white lie. I think that may help in a way. So, like I said, you need to know the thesis title. The second thing you need to know about the methodology, the statistical analysis. These three areas you need to really emphasize. And if at the end they ask whether you use, this is about the critical appraisal. I'll just show a small study just to give an orientation of it. Okay, so is the PDF visible to all?
Yes, sir, visible.
Okay, so I think this is the early drain study. I think most of you are aware of this. I'll just go through it very quickly because I will not go into the real contents of it. What you need to see from an exam perspective is what I wanted to emphasize. When you see this first page, delete it from your mind. Go directly to the second page. So on the second page, here itself, you will have the question. This is the clinical question. So here itself, you can underline it and keep it. That's so this is the clinical question. So fast reading, but you don't have to mention much about this because this will not be what is important for your critical appraisal. The next is about the picker. Years and older and present with an
Your
SAH
voice
diagnosed
is
by
breaking.
CT and considers your population. Okay. Now is it okay?
Yes, sir.
Okay. Okay. So I'll just repeat it again. In PICO, you have the population group. In population, you have patients more than 18 years presenting with acute SAH diagnosed by CT and confirmation of an aneurysm by CT angio or DSA. So this will come as your population. If you come down here in the trial procedures, usually they will mention about the intervention. So here in the lumbar drain group, a lumbar drain was placed in a sterile technique after aneurysmal treatment was done. That can be either clipping or coiling. And lumbar CSF diversion was started after a procedure, post-procedural CT scan was done. So the duration that was done was for at least 4 to 8 days. And the amount that was taken was 5 ml per hour. So this will be your intervention. So the control is patients who do not have a lumbar drain. So that is pretty straightforward. So you have P, I, and C. Then you come down. If you come down, you have the primary and secondary endpoints. That is your outcomes. So the primary endpoint is the rate of unfavorable neurological outcome at 6 months. That is given by the modified Rankin scale. Here they mentioned about what are the components of MRS. Please don't go through that and all. You will not have time. Your main thing is to see what is the primary endpoint, whether it is a subjective score or an objective score. Here they've used the MRS, which is an objective score. Then you look into the secondary endpoints. So the rate of secondary infarcts not being present in the post-procedural CT scan that is immediately performed after aneurysmal occlusion. Then they would have mentioned the definition for that. So that you don't have to mention. Then you can look over here. They would have mentioned the Glasgow outcomes, the rate of vasospasm. Then they would have mentioned the rate of infections, include device-associated meningitis. So these are your secondary outcomes. So based on this, you have the PICO and the clinical question ready. So that's the first part of the thing that I mentioned about. So the next thing is about assessing for internal validity. So the first thing you can read through is the trial design. So here itself they have mentioned it was a pragmatic. Pragmatic means it is a practical. Practical meaning you can apply it even to your patients. Multi-center. Multi-center, if it is there, it means that it has a good external validity, because people from different geographical locations will have different biochemical and lot of variations in the body composition. So that may affect outcomes. But mind you, always see the countries that were included, because here they have mentioned Germany, Switzerland, and Canada. That's good enough. But there will be some trials where they have mentioned 18 hospitals from Paris, France. That means it is within the same country, but they have taken different centers. That does not provide a good external validity, because everything is within the same country itself. So that needs to be looked into. So parallel group. Parallel group is the conventional group that is being done. The opposite of it is crossover trials. So this is also fairly okay. So you have three good things that are there. But the bad thing starts here. It is an open label. Open label means it is an unblinded study. Thing is, from a practical perspective, doing a blinding for patients with lumbar and not lumbar is practically not feasible. But since they mentioned it about open label, you need to mention that there is a very high probability of bias. Thing is, patients will be mostly intubated. So the heart on or observer bias is totally out. But the second one, the interventional bias, is likely to occur because of the blinding not having been done. And you can see that randomization has been done. So if you see over here, the randomization is mentioned. It is being randomized using a block randomization technique. So discussing the differences between block and stratified randomization will take a lot of time. I'll personally take photos and upload it in the group. That will give a better perspective of what I'm trying to emphasize. So the important thing here is they have used block randomization. That is fairly good. So you can see that among all these areas so far, you can see that open label was the only bias that was present. Then you further come down, and then you see the statistical analysis that was being done. In that, you need to assess the sample size technique that was used. So for sample size calculation, always see if they have taken anything from the previous studies, because based on the previous studies, they take the calculation of that sample size, then they multiply it by the precision and the possibility of an alpha error that can be avoided. Usually they take it as 85% power and 5% of an alpha error. So based on this, based on the previous studies, they come to a conclusion about the sample size. But this study had a problem with that, because they had actually gone based on the LUMAS trial, but it was not available. The data was not available at that time. So they had come with an assumption that based on calculating for 300 patients, they were able to come to a conclusion that if they take these 300 patients, then the power of the study would be good enough for the results being accurate. So if they ask you about the sample size, how it has been calculated, always check whether it is being based on a previous study that was present. If they have mentioned randomly based on some numbers that have mentioned, like over here, say that it is not very clear. That is more than enough. Then if you come little more down, you can see here that the categorical data were assessed with the chi-square test and continuous data with the Mann-Whitney U test. So these two are there. And here, if you can see, they have mentioned about intention to treat analysis was done for all patients. And in a very small subset of patients alone, per protocol analysis was used. So this, if you see in the later slides, later part of the article, you will find out that the contribution to this subset of patients is very minimal. So the per protocol analysis per se was not very significant. So I have not mentioned much about this over here. Then they mentioned about logistic regression, then about the mortality groups with Cox proportional assets. Those areas you don't need to really bother about. So then you see the consort diagram. So this is one thing I was saying. You see whether it is uniform in both the groups. So you see that 307 are there, 155 and 152. So it's almost equal. 11 were excluded, 9 were excluded. That is also good. The important thing is you need to see through the why the patients were excluded. So if you see that if anything is there that is relevant, it is good enough. But there may be some very weird reasons in few studies why they have been excluded. So those need to be taken into consideration. There was one big flaw in this COMSORT diagram, that was once the randomization was done and the study had been initiated, in the interventional group, 35 patients had undergone protocol deviations. But here only 2 patients had undergone protocol deviations. So you can see there is a wide discrepancy in these 2 groups. So that itself can create a bias. So that also needs to be kept in mind when you explain whether you will use the study or not. So if you ask me, I will not use it because I've already detected 2 biases. Then the next one is about the enrollment. So they said that the first patient was enrolled in 2011. But 2016 was when they finished the enrollment. They've taken 5 years. So I told you, if there is going to be a time lag, that is going to affect your interpretation of results. Even though objective parameters only were used, but the time lag being so much itself is likely to create a bias. So that is also another thing to be kept in mind. So always see the duration of study, because for our thesis, it will be between usually 1 to 2 years. So that's not a problem. But when they do such a big study, it has to be having a lesser risk of a time lag bias. So after that, here they would have mentioned a lot of words relating to the statistical about this interquartile range, median, and all that. Please don't waste time seeing all this. Straight away come to this one table. This will give you all the information that is being mentioned in this. Whatever they have mentioned here as table 1 will be what is here. So when you see the distribution of data, always see if there is similarity in both the groups. If it is there, then you don't have to be very much concerned about it. As you can see, difference about 5 to 10 in each group. So that is fairly acceptable. Then we'll come up to the next part of it, analysis of primary and secondary outcomes. Now, the trick over here is you see the p-value. Wherever you see that the p-value is less than 0.05, put a circle around it. If you see over here, there is a 0.04, then here there is a 0.04, and here below there is a 0.009. You circle it and see for which data there has been a statistical significance. So here you can see that the MRS score at 3 to 6 at 6 months, and infarct at discharge, and Glasgow outcome scale at 1 to 4 at 6 months. So these 3 values were significant. So you can just underline it and keep. So that will be aiding you at the end when you present it to the examiner. This is very important. Sometimes in the post-hoc analysis, they would have found something significant. Vasospasm detected by clinical means, all this and all has been mentioned. And infarction at discharge was associated with unfavorable outcomes at 6 months. So this was the secondary analysis findings that they had found about. So once you have done this itself, you would have covered most of the parts of the critical appraisal. Then the next thing is about the subgroup analysis. Here they would have mentioned that is like age, sex, and all that they would have assessed, and they would have seen whether it favors lumbar drain or the standard of care. This is almost like a forest plot. The only thing you need to look is whether this confidence interval line crosses this line of unity. So if it touches or even crosses this line of unity, then it is insignificant. So you don't have to bother about it. So you see that in all of this, it is crossing the line of unity, except for modified Fisher radiological grade, that is grade 4. So in this subset of patients alone, they've shown that use of a lumbar drain is found to be favorable in this subgroup of patients. So this is about the basic idea about how to critically appraise. So what I would personally suggest is, before you go for the exams, take at least one of the recent studies that has come up, like the balance trial, something like that. Practice it in the format that you had given and try to finish it within 10 to 15 minutes. So that will give you an edge when you apply for the exam. I have a small cheat code. That is, in most of the studies, they would have mentioned about the limitations. If at all you're totally stressed out and you don't know what to do and you don't know like where to go about it, then you just read through the limitations. In that itself, they would have mentioned at least 2 to 3 limitations in that trial. So you can just see through the limitations and then you can again read that part of the section Like here they mention about we did not collect data based on. Yeah. Although this may be a source of error, blinded outcome assessment of radiological imaging at 6 months minimize this potential. So all this was being mentioned here. Like we had mentioned in the beginning, right? Blinding was not done. So they have mentioned about all this. Patients, relatives, and acute care clinicians are not blinded in the intervention. So if you are not able to have a clarity, you can see this and then go to that part of that paragraph and underline it. So this will give you an idea about how to critically appraise. I hope this gives you a basic understanding. My personal request is practice at least one paper before you go for the exam. Because if you do more than that, well and good. And if you have the time for it, all the more better. But my personal suggestion would be to at least practice one paper. So this is about the critical appraisal. So we'll next go to the ECGs. If you have any doubts, I'll happily clear it in the WhatsApp discussion because we are already delayed by half an hour. So I'll finish this and then again I'll discuss whatever queries you have in the WhatsApp group. Okay. Okay. Is my slide visible to all?
Yes, sir, visible.
Okay. Okay, now for ECGs, I personally need all your participation because we'll try to finish it as early as possible, but we need to identify certain things at a fast rate so that one-sided talk. So you can either do it through chat boxes or you can tell it verbally also. So either way is good enough. So we'll proceed immediately. So when they give you an ECG in the exam, always go in a systematic format, like how you go for X-rays. You go with the rate, rhythm, axis, P, QRS, PR, QRS. These are areas where you already have an idea about. So the PR interval normal is 0.12 to 0.2. QRS is 0.08 to 0.12. Then ST segment, you assess for J point elevation. Then you need to assess the corrected QT, that is less than 0.44 seconds. And U wave, what it signifies is repolarization of the papillary muscles or the Purkinje fibers. So this is the basics that need to be kept in mind. All of you would definitely know about it, but just for revision purposes, when you are when you're being asked the ECGs, always go in this format. So diagnosis. Sorry, I think I gave the answer itself. So this one is, I think it's pretty straightforward. It's an atrial fibrillation. So you can see that that's irregular rhythm and no P waves, absent of isoelectric baseline, variable ventricular rate. So the fibrillatory waves may mimic P waves, leading to misdiagnosis. So that's one thing you need to keep in mind. Very good. At least there was one guy who's answered. Thank you. So the next one, diagnosis. We'll take 10 seconds. If it goes more than that, then we'll go to the answer. Please participate. It's for your exam purpose. Okay. No, actually, the answer is second degree heart block, Mobitz 2. Priyojot got it right. So I think you all are aware of this, the basic ECG heart blocks. First degree, second degree, Mobitz 1, Mobitz 2 is there, and third degree. Third degree invariably will be kept in the exam. So if you have confusion, always see at least 5 to 6 ECGs related to that, so that you have a clarity. Diagnosis. Super. It's not SVT, it's flutter. It's a flutter. Okay. So super. So much of cooperation is there. So basic ECG features of flutter are One is it is like almost like an aerocomplex tachycardia. It's regular atrial activity at 300 beats per minute. There'll be loss of isoelectric baseline. You will have this typical sawtooth pattern. So that is what characterizes it. All right. So upright flutter waves in V1 that may resemble P waves. So I think many of you got confused with SVT because of that. And the ventricular rate depends on the AV conduction ratio. So this is just for identification purpose. But like I said, when the exam they ask you, always go in a stepwise manner. Diagnosis. Super. Okay. So we got the answer. It's pretty straightforward. It's in a ventricular fibrillation. So if at all you have ACLS, usually they'll have this simulation ECG simulator. So they'll keep changing the rhythms however they like. So this will be definitely one of the rhythms that will be kept. Okay. Diagnosis. Superb. Okay. Yeah, exactly. It's a Torsade de point test. That's a polymorphic VT. Okay, excellent. So the important thing you need to know is patients who have a frequent VPCs are at very, very high risk of developing an R-on-T phenomenon that can trigger a polymorphic VT. Okay. So this is one thing I wanted to emphasize. So we have the twisting that occurs. So this is another picture that is here. You can see the R-on-T phenomenon that occurs, and that will trigger either a TDP or that itself can progress onto ventricular fibrillation. Diagnosis. Nice one. Nice try. Nice try. Keep trying. Keep trying. Superb. Superb. I think Amarnath got it right. So this is supposed to be a image of hyperkalemia. Okay. So you need to know about the potassium levels and the ECG changes that are associated. So if it is 5.5 to 6.5, then there are going to be peak T waves. 6.5 to 7, P wave widening will be there, or they can be flattening. There will be PR prolongation, and P waves will eventually disappear. All right. Between 7 to 9, there will be bradyarrhythmias that can occur because of conduction blocks. And if it is more than 9, you can develop life-threatening rhythms. So usually there will be pulling that will occur in hyperkalemia, pulling of all the waves. So you can see in hyperkalemia, there will be peak T waves, that P wave will be flattened, there will be PR prolongation and white QRS. So that is how it was there in the previous slide. So I think once you've seen this, I hopefully you guys won't forget it. So similarly, hypokalemia is like a pushing down. So you will have T wave inversion, ST depression, and a prominent U wave. Okay. Diagnosis. Sorry, that's not the right answer. You're actually the content of it is right, but there is for hypothermia there needs to be shivering artifacts and there needs to be severe bradycardia. It's not there. So that is why I put this tricky ECG. It's supposed to be severe hypercalcemia. So when severe hypercalcemia is there, that is like ionized calcium is more than 4.1, you can see Osborn waves. That is why it specifically put this kind of like out of the box ECGs. So as you all know, in hypercalcemia, there will be shortening of the QT interval. And in severe hypercalcemia, Osborn waves can occur. And worst case scenario, ventricular irritability, that VT or VF can occur. So that is the most important things you need to keep in mind. So we all know that hypercalcemia is associated with QT shortening, but in severe cases, Osborn waves can occur. Okay. Diagnosis. Come on, I just discussed about it a few minutes back. It's not hyperkalemia. Gautam had told the right answer. Gautam, then Jagan Prashant has told, then Doxyazi has told. Exactly. Roshni has also told there's a U wave. So this is supposed to be a typical hypokalemic ECG. All right. Excellent. Excellent. So here you have an increased P wave amplitude, prolongation of PR. Then there is a wide spread ST depression and T wave flattening or inversion and prominent U waves. That can be best visualized in lead 2 and lead 3. All right. Okay. And the important thing is in severe hypokalemia, that can cause tachyarrhythmias. So if it is hyperkalemia, it will be more associated with bradyarrhythmias or conduction blocks, manifesting as conduction blocks. Whereas if it is hypokalemia, then it can go with significant tachyarrhythmias. So that needs to be kept in mind. So this is just an image I wanted to show. Patient had severe hypokalemia and then eventually developed a QT prolongation, and that led to a torsades pontus. Okay. What do we see over here? I think it is Nikita has told us W or W. WPW, yeah, correct. It's WPW, exactly. Here you can see the delta waves that are present. Okay, so this is when you if you go in a systematic manner, you can see that the PR interval is markedly shortened. So that is one way that you can identify about WPW syndrome. Excellent, excellent, super. Okay, diagnosis. Superb, superb. That's the answer. This is a typical hypothermia ECG. See, you can see shivering artifacts that there are significant bradycardias there, and here you can elicit J point. Okay, here it is more evident. Okay, sorry, not J point, the Osborne waves. Okay, so that's about it. So bradyarrhythmias, Osborne waves, prolonged PR, QRS, and QT, shivering artifacts. All these need to be there. Okay, so this is what. So this one, Osborne wave is a positive deflection at the J point. Okay, so this is what I wanted you all to have a look into. So you see that it's almost in sinus rhythm. There is no shivering artifact, but Osborne waves are present. Then it is highly suggestive of severe hypercalcemia. But in this scenario, it's more consistent with hypothermia. Okay. Diagnosis. Yeah, it's there. I personally would like everyone to have a look on the S wave on one lead 1, then the Q wave in lead 3, then the T wave in lead 1 again. Yeah, exactly. So that's the final answer. See, this ECG is going to be very uncommon. But since I told you about S1, Q3, and T3, my next question is going to be, what is the name of that sign? Any guesses? It's called McGinn, McGinn, white, WHIT sign. It's called McGinn white sign. That's the other name for S1, Q3, and T3 sign. Okay. So if at all they ask you in the exam what is McGinn white, then you have to don't be very much surprised. It's just the S1, Q3, T3 part. Sorry, S1, Q3, T3 pattern that is seen in pulmonary embolism. So the other manifestations that can be there is RVVB that you had seen, and many of you had answered. S1, Q2, 3 can be there. T wave inversions can be there. But the most important and most common finding is sinus tachycardia. So that is, if at all you get a P case, they may ask you what is the most clinical sign that can be found on ECG. All right. Okay. Diagnosis. It's not pericarditis. Yeah, alternance is there, but what is it? Do you think effusion causes this kind of ECG, or is there anything severe enough that can produce this kind of picture? Exactly, exactly. Vinay has told, Dinesh has told. Correct, 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 correct. Okay. So thing is, pericardial effusion usually does not produce this kind of alternance picture. It is more of so massive pericardial effusion filled pericardium. So if they keep this, please don't say the answer as if you look in one of the leads alone, I think you will probably get the diagnosis. Someone has asked me a question. It's been proper. Yeah, it's not properly placed. Or is it? Okay. So this is supposed to be actually a dextrocardia. So here you can see marked right axis deviation, global negativity in the lead one, and positive global that's lead positivity in AVR, and absent RV progression in the precordial leads. Okay. So that is one of the ways to identify it. All right. Okay. So if I had just put this ECG, it will not make sense. So I thought I'll make it like a scenario. So we had this kind of case actually. So there is a 24-year-old male who was a known case of type 1 diabetes. He had actually presented with sudden onset giddiness and drowsiness while playing basketball with his colleagues. So he was immediately brought to the ER, and then they found this rhythm. Super. Jasmine had told the right answer. Jasmine Pratap Reddy is also told the right answer. It is Brugada. All right. So you have two types of Brugada. From an exam perspective, we need to know about it. You have type 1 where there will be a ST elevation with the downsloping ST segment, whereas in type 2, you'll have a saddle back pattern. All right. Fine. Next one. No, the answer is not STEMI. Again, Jasmine got it correct. Vinay got it correct. It's pericarditis. Okay, sir, you can see there is global ST elevation that is present. Okay, widespread concave ST elevation and PR depression throughout most of the limb leads. All right, and reciprocal ST depression and PR elevation and lead AVR. And anyone has an idea what spodic sign is? If at all they keep a pericarditis ECG, they may ask what is spodic sign. Okay, no issues. See, it's just that once you have an ST elevation, there will be a downsloping of your TP segment. That may be an early manifestation seen in 30% patients with pericarditis. Okay, so it is best visualized in leads 2 and the lateral precordial leads. Okay, so that is about spodic sign. So spodic sign is downsloping TP segment. Okay. So identify the abnormality and the associated condition related to this. Sorry, no, no. Any other guesses? I don't think it's a complete hard block. No, not SAH. Okay. So this is supposed to be the digoxin effect. Yeah, exactly. Umadri Singh has told the right answer. So digoxin effect is basically downsloping ST's depression with a characteristic reverse tick or Salvador Dali sagging sign. Okay. So it is flattened, inverted, or biphasic T waves with a short and QT interval. So this indicates digitalization. The important thing, it does not actually correlate with digoxin toxicity. It just gives you an idea that the patient is taking digoxin. That's it. So that is one of the ECGs I thought you guys should know about. Okay. Patient with recent ACS and with intermittent episodes of angina. Diagnosis. There is something very, very characteristic. Excellent, excellent, excellent. Jasmine has told, Omkar has told, it's Valencine. Okay. So this is also another manifestation of Valencine. Okay. So the first one is type valence type A, and the second one is a valence type B. Here you'll see there is a typical T wave, deep T wave inversions. Here you can see there is a biphasic T waves. Okay, so that is important thing. The significance, I think most of you would know about it. Okay, so it's a clinical syndrome characterized by biphasic or deeply inverted T waves in V2, V3, plus a history of recent chest pain that has now resolved. So the main significance is it is highly specific for a critical stenosis of a LAD. So when the patient is in a pain-free state, you will find these features. But when the patient is having anginal symptoms, you will see that there is pseudo-normalization of these findings. So the important thing is you need to see serial ECGs on a daily basis in this subset of patients. All right. So among both of these, biphasic or deep T, this one is supposed to be more common. Diagnosis. Okay. So I'll just go through that image again. So you can see these images. If you actually put these images in the mirror image, you will find it almost like an ST elevation. Yeah, one guy, Dr. Rowe has told it correctly. It's actually a posterior wall MI. Okay. So it is suggested with the presence of ST depressions in V2 and V3. There will be tall broad waves, broad R waves in V2 to V3, dominant R wave, that is RS ratio more than 1 in V2, and upright terminal portions of the T waves in V2 to V3. So here you can see ST depressions are there markedly. So when you do a reciprocal reversal, you can find that there will be ST segment elevations. So here, if you see the leads that need to be placed, it will be on V7, V8, and V9. So that is V7 will be in the left posterior axillary line, 8 will be in the tip of the left scapula, and 9 will be the left paraspinal region. So this will be the location of leads that need to be kept. And once you do that, you will find that the lead reverse, once the leads are placed in the posterior part, then you can see the ST elevations more markedly visible. All right. So I think two people had got it right. One is Omkar and the other one is Dr. Ro. Okay. Next diagnosis. Since you told posterior NMI, I think this one would be relatively straightforward. Superb. Superb. Almost everyone are coming with the answer. Excellent. It's not. Oh, I think one person got it wrong. It's not anterior wall MI. It's supposed to be a RVMI. Okay. Many are told inferior wall. In patients with an inferior wall with this kind of picture, you always need to suspect an RV wall MI. So what do we suspect it based on? So you see that there is a ST elevation in V1, then ST elevation in lead 3 more than lead 2, then ST elevation in lead 1 with ST depression in V2. that is highly specific for an RV infarction. So these areas you really need to concentrate. So then you need to place the leads, like how you place the leads for on the left side, you need to place it on the right side. So if you do that, you will get the images. So here you see in V4R, you will have ST elevations. So that is consistent with an RV infarction. All right. So why I wanted to make this slide specifically is you guys will definitely pick up anterior, anteroseptal, lateral, inferior. But posterior and RVMI are areas you may miss. That's why I specifically wanted to mention in my set of images. Okay. Okay. So what can you see over here? Just giving a clue. Excellent. Someone has told. Okay. L6. Excellent. 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 Super. So I think everyone knows about the localization and areas and all. I think I don't have to emphasize on that because these are things that we've been seeing for the last 3 to 4 years. So I think you guys are really clear about it. Only things I want you guys to emphasize is on RVMI and posterior MI. Since you guys don't see that so frequently, you need to practice at least 4 to 5 ECGs related to that so that you don't make a mistake in the exam. So in any patient with whom you see there is an inferior wall MI, always in the back of your mind, always think if there is anything that is suggestive of an RVMI. All right. And similarly is for posterior wall MI. If you see that lead localization is not very convincing, always in the back of your mind, always think about a PWMI. Okay. So I think we finished about all the ECGs. So thing is regarding pacing, it may be kept either in your hemodynamic monitoring station or they may keep it in equipment. So I just wanted to give you an overview. So for temporary pacing, so temporary venous cardiac pacing involves electrical cardiac stimulation to treat symptomatic bradyarrhythmia till it resolves by itself or until long-term therapy can be initiated. So this is one thing which all of us know. So the main purpose is to re-establish normal hemodynamics that is acutely compromised by a slow heart rate. So the pacing techniques is internally using transvenous, externally using transthoracic patches, again using internally using atrial or ventricular epicardial leads that is placed during surgery or through an esophageal electrode that can be used for atrial pacing and recording also. So main indications is electrolyte imbalances, hyperkalemia or hypercalcemia, drug toxicities, post-procedural. That can be the injury to the SA, AV or his bundle fibers. During post-cardiac surgery, post-heart transplant or TAVI, that's transaortic valve implantation. Then infections like Lyme's disease, Chagas, subacute IE, that can be damage to the His-Purkinje fibers. Acute MI itself can produce this kind of bradyarrhythmias and permanent pacemaker revisions due to PPA infections or lead failure. The important thing is this temporary venous pacing should be kept for the shortest time possible because if it is kept for a long time, the infection rates are high and it can lead to infective endocarditis. That is going to be a bigger problem to deal with. So contraindications, if they ask absolutely the contraindication, there is none. But if there is a prosthetic tricuspid valve, there is a risk of injury. So preferably avoidable. But if it needs to be done, it needs to be done. And if the patient has received thrombolysis due to the risk of bleeding. So preferred procedure, you all know, preferred access is IJV or subclavian. So transvenous lead placement, only the ventricular lead is inserted. So it is almost like a CVC insertion. The only thing is once you put the dilator, you first put the sheath inside. So once you pass the sheath, you then pass the transvenous lead and advance it based on the markings on the tip of it. It can also be confirmed with ECMO or fluoroscopy. And continuous ECG monitoring is important because VPCs or non-sustained VT can occur when it comes in contact with the RV. Then it is connected to the pulse generator. So for pacemaker programming, the general mode that is kept is VOO. So that you need to keep in mind. So if they keep the pacemaker machine over there, they will ask you what are the settings that are there and how will you initially set the settings. So that is one thing you need to know about. So the heart rate usually is kept between 60 to 70 beats per minute. The pacing sensitivity is initially kept, and then it can be adjusted between 0.8 to 20 millivolts. So if it is sensitivity, the unit is millivolts, S for V. So what is sensitivity? It is the minimum current at which the pacemaker is able to sense intrinsic rhythms. It is expressed in millivolts, and the lower the number, the more sensitive the pacemaker. The lower the NNT, the better the intervention. Similarly, coming to the pacing threshold, it should be less than or equal to 1 milliampere. So the pacing threshold is the minimum pacing output required for the pacemaker capture. So the minimal pacing output at which the action potential is generated, leading to a myocardial contraction. So that is the pacing threshold. So it should be less than or equal to 1 milliampere. And the pacing output should be 2 to 3 times of the pacing threshold. So what is the pacing output? It is the current with which it produces a brief pulse. So these numbers need to be memorized. So if they ask you the sensitivity, it's 0.8 to 20. You initially keep it at max and then adjust it so that you keep it as low as possible. The lowest one which can sense the rhythm, which the pacemaker is able to sense intrinsic rhythms is the sensitivity. Then the pacing threshold should be output should be 2 to 3 times the pacing threshold. So the complications, it is important to monitor for all of these when the transpacing is present in situ. So lead dislodgement or disconnection, bleeding, myocardial perforation that can lead to cardiac tamponade, pneumothorax infections, catheter knotting, or air embolism. So post-procedure, if they ask you what you need to examine in that patient for, you'll have to mention, you'll have to assess for presence of a pericardial rub, which may be indicated for cardiac perforation. There may be presence of cardiac tamponade, which can occur. Then hypertension with muffled heart sounds is again suggestive of cardiac tamponade. And asymmetrical or absent breath sounds can be suggestive of pneumothorax. But now currently in the era where we do ultrasound guided blocks, ultrasound guided lines, it is very, very uncommon. So with regard to the 2021 guidelines on cardiac pacing, pacing is indicated in patients with bradycardia, tachycardia form of sinus node dysfunction to correct bradyarrhythmias and enable pharmacological treatment unless ablation of the tachyarrhythmia is preferred. All right. So mainly in tachybrady form of sinus node dysfunction, it is indicated, and in patients with atrial arrhythmias and permanent or paroxysmal third or high degree AV blocks, irrespective of the symptoms. So in these two scenarios, it is recommended. So coming to the permanent pacemakers, so this one is general concern. Like, why do we go with permanent pacing? If there is symptoms, dizziness, lightheadedness, syncope, and fatigue, all are related to bradyarrhythmias, and the location of the conduction abnormalities. Usually, if it is infrahis AV blocks or second degree morbits or third degree blocks, usually the chances of spontaneous recovery is going to be very less. So in these kind of cases, temporary pacing will not help. They'll need to go with permanent pacing. So you have class 1 and class 2 indications for permanent pacemakers. So class 1 is symptomatic brady, symptomatic sinus brady due to long-term drug therapy of a type and dose for which there is no other accepted alternative, complete heart block irrespective of symptoms, and symptomatic second-degree heart block. And class 2 recommendations is sinus node dysfunction with unexplained syncope, asymptomatic second-degree heart block, then bifascicular or trifascicular block associated with syncope, and post-anterior wall MI. So here contraindications are that, like if there is excessive risk of bleeding due to vascular access, ongoing bacteremia, presence of an intercardiac thrombus, or a prosthetic tricuspid valve. So these are that. Definitely it is not an indication to proceed with a PPA. So parts of it are battery, circuit, leads, and the electrode. Okay. So the pacing nomenclature is, you can remember it as PSR, RT. Okay. P is supposed to be the pace, chamber paced, chamber sensed, the response to sensing, that is trigger, inhibited, or dual. Then the rate modulation, whether it is there or not, and multi-site pacing or anti-tachycardia mechanisms. So what is rate modulation is, it uses a physiological sensor rather than sinus node to adjust the pacing rate according to the physiological needs of the patient. Like if patient is exercising, accordingly it will help to adjust it. This multi-site pacing is for anti-tachycardia or resynchronization function, but it is not commonly used. This is just from my exam perspective. You need to know about it if at all it is asked. So about overdrive pacing and anti-tachycardia pacing, it creates a re-entrant pathway that bypasses the AV node or an ectopic unregulated pacemaker. So disrupting the re-entrant circuit or overriding the ectopic pacemaker, it helps it to change the pattern of the repolarization, creating more uniform repolarization. So easy to understand is if at all there is a severe tachyarrhythmia that is occurring due to a re-entering mechanism, if you increase the heart rate more than the rate which is present, it will help to terminate it. So that is the easiest way of explaining it. So in refractory VT, overdrive pacing increases the rate of depolarization, decreasing the ventricular refractory period and reducing the susceptibility to the R-on-T phenomenon. So in AV junctional tachycardia, atrial flutter, and SVT with rapid ventricular response that fails to revert with medical therapy, overdrive pacing can be attempted. And an external electrical impulse at the rate of 10 to 20 beats per minute greater than the native rate is what is usually prescribed. So these are some ECGs related to pacemakers. So here you can see normal atrial and ventricular pacing spikes. Here you can see that there is a atrial pacing and there is a ventricular pacing. So that produces the rhythm. So two pacing spikes are there. Here there is predominantly just a ventricular pacing that is present. That is the ventricular pacing spikes precede each QRS. All right. So pacing abnormalities. Here you can see there is failure to capture or pacing failure. This is one among the most common abnormalities that is seen, especially with the transvenous. So ventricular spikes follow the P wave, but there is no pacing thereafter. All right. Here you can see. Here the small spikes are there, but after that there is no depolarization of the ventricles that occur. So there are various etiology for pacemaker dysfunction. It can be that's failure to pace, lead dislodgement or malposition can be there, inflammation of the electrode surface can be there, battery depletion, pulse generator failure, lead maturation, or magnet application. So for most of these, the main treatment is reposition of the leads, changing the battery, changing the generator, or you need to remove the magnet if it is present. So rapid ventricular pacing, this was seen in the previous generations of permanent pacemakers. So rapid ventricular pace rhythm with no evidence of preceding atrial activity. So there are two possibilities. One is pacemaker mediated tachycardia and sensor induced tachycardia. So for that, the main management is initial management is you place a magnet and change it to asynchronous mode. The definitive management is reprogramming of the pacemaker. So these are the two things that need to be kept in mind when you have a pacemaker mediated tachycardia, because if it goes into a severe tachyarrhythmia, it will compromise on your cardiac output. So this is runaway pacemaker. This is paroxysmal of rapid pacing spikes at 2000 beats per minute with decreasing amplitude and rate. This fails to excite the ventricles due to the low amplitude spikes. So this also again leads to low cardiac output states. So here also you you inhibit the activity use of magnet, then you proceed for temporary pacing, and then definitive management is reprogramming the pulse generator. So complications are similar to what we had discussed previously: lead dislodgement and disconnection, bleeding, myocardial perforation, pneumothorax, infections, catheter knotting, air embolism, runaway pacemaker, and pacemaker mediated tachycardia. Okay. So what abnormality can you identify here? Anyone? LAD. But here we don't have any of the chest leads, right? Anyone else? Superb, superb. Vinay stole the right answer. See, this is basically a left anterior fascicular block. Okay. So here there will be left axis deviation. Okay. Left axis deviation is present. There's a positive deflection in one and negative deflection in area. All right. Then along with that, there will be a small Q and a big R complexes in one and AVL that is present. Okay. Then you have an RS complex in 2, 3 and AVL. Okay. That is also present. So these are the three important things that need to be looked into. And there will be also prolonged R wave peak time in AVL. Okay. So that is one thing you can identify LAHP. That is left anterior hemiblock or left anterior fascicular block. So that's why I want to keep this towards the end. So patient was brought in an unconscious state, intubated in ER. ECG showed the following. What are the abnormalities seen and what are the diagnosis? SCT with aberrant C. Sorry. No. You need to assess, like I said, go in a systematic manner, assess the P wave if it is present, see the QRS, see the T wave, see the ST segment, see the QT if it is visible. Again, no. See the question properly. Patient was brought in an unconscious state, intubated in ER. Junctional rhythm, definitely no. Any two more questions, two more answers possible. SVT, no. Trifascicular, definitely not. Okay. This is supposed to be a ECG of a tricyclic antidepressant overdose. All right. So, thing is, toxicology related ECGs are going to be very few. So, this is one of the few ECGs that are very, very characteristic. Okay. So, that's why I wanted to emphasize on this one also. So, the main things that we need to look into is QRS widening if it is present or not. Okay. So, if there is QRS widening, it indicates intraventricular conduction delay. Then there will be sinus tachycardia, mainly because you have multiple receptor blockade which occurs because of PCA overdose. Here in sinus tachycardia is because of the muscarinic receptor blockade. So that causes a tachycardia. So here you can see there is a QRS more than 100 milliseconds. Sinus tachycardia is there. And the R wave will be more than 3 millimeters in AVR. And the R dash will be dominant in the AVR. So based on these findings, you can make a diagnosis of PCA overdose. All right. My personal suggestion is, since many people are not able to answer this one, posterior wall MI and RVMI, please revise these ECGs before the exam because these may come as out of evox ECG. So this is just a basic list of ECGs that can be possibly kept in the exam. So I just wanted you guys to have an overview of this. So we have covered almost everything of this. Certain ECGs are pretty straightforward. So I did not want to cover all those aspects, but these are the ones you really need to have in mind. All right. And keep revising these ECGs before the exam. So we'll come to the last part of this. So I need volunteers for this because this is simulation based. All right. So you have a 65-year-old female, a known case of COPD, hypertension, and diabetes, was admitted in your ICU with history of cough and breathlessness, diagnosed as a case of community-acquired pneumonia, initiated on antimicrobials and non-invasive ventilation. So during the course of rhythm, you see the patient and how will you proceed? please don't through your ACLH tachycardia protocols. You just tell whatever you know, accordingly you proceed. No, please don't mention it in the chat box. You can directly answer it. Anyone who's willing to give it a try, because in exam they will ask you, you will need to answer this. Okay. So I think very few people are interested in the answering part of it. Anyway, so due to want of time, you go with the AHA protocol, you assess the appropriateness of the clinical condition. If the heart rate is more than 150 beats per minute, you need to identify and treat the underlying cause. You go according to the AHA. Maintain a patent airway, assess breathing as necessary, oxygen if hypoxic, cardiac monitor to identify rhythm, plus monitor BP and SpO2. If an IV axis is already there, not to worry. If it is not there, please secure and get a 12-lead ECG. So, if there is persistent tachyarrhythmias causing hypotension, altered mental status, chest pain, signs of shock, and acute heart failure, if all these are there, you directly go with shocking, that is synchronized cardioversion. So, at that point of time, consider sedation. Airway equipments to be kept at the bedside, because sometimes when you give a shock, that patient may go into cardiac arrest. So, that time you need to keep everything ready for resuscitation. So if it is a regular narrow complex, consider iodinosin. But in our case scenario, that is not feasible because the patient has a history of COPD or medical therapy. So if you give adenosine, it is going to cause bronchospasm, and that is going to further worsen the breathlessness. So highly not recommended to go with adenosine. So if it is refractory, then you need to assess the underlying cause, need to increase the energy level for the next cardioversion, because this was a paroxysmal supraventricular tachycardia. The amount of joules that is needed is between 50 to 100. So you can start with 50, 75, and then go to 100. Sorry, there's no 75. You start with 50 and then go to 100. Then addition of an antiarrhythmic drug and get an expert consultation. So for synchronized cardioversion, the dosing for narrow regular is 50 to 100, narrow irregular 120 to 200. That is for atrial fibrillation. Wide regular is 100 and wide irregular is defib dose. That is not synchronized. So the next thing is, if there is persistent tachy which is not there, the next thing is you assess whether the QRS is wide or not. So this patient has a narrow tachycardia. So the first thing you can consider is vagal maneuvers if it is regular. Adenosine, but not in this case. Beta blockers, again, not in this case. You can go with the calcium channel blocker and expert consultation. So calcium channel blocker, if the patient is not in shock, you can go with either diltiazem or verapamil, or these are the two options that you can consider. Whereas if it is a wide QRS, then you can consider adenosine, but in this case, again, antiarrhythmic infusions like amiodarone, procainamide, and sotalol. So again, if it is refractory, you need to assess the underlying cause. So the most probable thing is you take an ABG. Since the patient was on diuretic, the probable precipitating factor could have been hypokalemia that could have occurred. Then they need to increase the energy level for the next cardioversion if patient is hemodynamically unstable, and addition of an antiarrhythmic drug and get an expert consultation. So this is the tachyarrhythmia protocol. I think most of you are already aware of this. You use it just for a revision. So the next one. 50-year-old male with no prior comorbidities was admitted with history of gastroenteritis. He was initially admitted in MOD. In view of breathlessness, he was shifted to ICU and evaluated to have acute kidney injury with severe metabolic acidosis, which was managed medically. In view of hypertension and heart rate of 78 per minute on day 3 of ICU, your junior decided to manage with use of beta blockers and subsequently gave an alpha agonist also, clonidine. At night, you get a call that the patient's heart rate is 35. You see the multipara monitor and find the following. So how will you proceed for this? So first thing is, like, what is the rhythm? Superb, superb, superb. Okay, it's sinus brady. I think that part of it is very clear. Thing is, usually they keep conduction blocks, but since these are real life scenarios that really occurred actually, so I just wanted to put these scenarios over there. So when there is a sinus bradycardia, the heart rate is less than 50, you need to be little concerned. So it's almost like what you did for tachyarrhythmias, but there will be some modifications regarding the initial part of it. So ABC, oxygen if hypoxic, cardiac monitor to identify rhythm, but most of the patients in ICU already have a multi-para monitor, but you need to monitor the BP and oxygen. IV access if it is not there, a 12-lead ECG. Consider possible hypoxia, MI, or a hyperkalemia. These will be your three top differentials to consider. And if it is a new patient who has been admitted to your ICU, always consider toxicological causes also, like beta blocker, CCB, digoxin, or OP compound. So if persistent bradyarrhythmias are there causing signs of hemodynamic instability are not there, you monitor and observe. But if they are there, you go with injection atropine. Okay. So once it is being given, usually it actually has to come as 0.6 milligram per kg, 0.6 milligram. My apologies, I've written it as 1. So then if atropine is ineffective, then you go for transcutaneous pacing, dopamine infusion, or an epinephrine infusion. And after that, even with that, it is not getting controlled, then you consider transvenous pacing and get an expert consultation. So for transvenous pacing, I had mentioned about it in the previous slides. So you need to know about the indications. Like I said, in the 2021 ESC guidelines, they have told tachybrady kind of sinus node dysfunction or with bradyarrhythmias, which are symptomatic. In those scenarios, you can proceed for it. So you also need to look into the contraindications. Absolutely, there are no contraindications for transvenous pacing, but for relative, tricuspid prosthetic valve that is present is contraindicated. And one more contraindication is possible presence of bacteremia. Okay, so in these two scenarios, you need to be cautious. So oral therapies that can be tried are theophylline can be given like in the dose of 5 to 10 milligrams per kg per day in divided doses. Omkar has asked whether isoprenaline can be given. Yes, it can be given, but unfortunately in the AHA guidelines, it has not been mentioned. So if they ask about it, please don't comment it. Your top priorities will be to go with dopamine and adrenaline. That is, if at all it is still ineffective with atropine. Thank you. So if anyone has any queries, please ask in the WhatsApp group that has been created. I'll be happy to answer. I'm very sorry for the net connection issues that were there. It was something which was untoward that had occurred. So Appas sir is there. I'll hand it over to sir. Sir, good evening, sir.
Good evening, Dr. Srihari. That was a very, I would say, lucid as well as a very comprehensive presentation from you, covering A to Z of the domains that you have actually discussed. So I hope this would be definitely helpful for the trainees as well as the candidates. So there are a lot of questions like answer. Then I would be happy to start my presentation. Okay, is my screen visible?
Yes, sir.
Okay, perfect. So I want to know how is the session till now, just to get the idea how it is going on and how you are getting the vibe inside you. You all can share in the chat box. Just to give 1 minute break before I start with the most important, I would say rather one of the most important part, that is short cases. So I have two real short cases that I would be presenting, and you all have to answer. So this is not theory. I will not be discussing the theory part, but yes, I would be summarizing the case, and the answers also simulated by the examinee. I would be answering, because it will not be possible for me to act, or I will allow you to answer, because it will take a lot of time. But definitely the answers that I would be framing, it would be by the candidates in the real exam. And this is the same thing that we have conducted in our on-site course that we recently conducted in Bangalore. So it would be something very interesting, and that was actually really appreciated by everybody there. So I would be starting now the short cases. So should I start? So I need one thumbs up from one of you. Okay, perfect. So without wasting further time, so these short cases, as Darshan has also in the initial presentation told, the short cases should be for short time only, and they are actually mark fetching, because the short cases should be mainly dealt with the specific case scenario, and there would be a specific domain around which the case would revolve. So now let's start with the first case. I want you all to participate, and we will be trying to finish everything in next 2 hours, because there are a lot of stations also I am trying to finish today. So when you will be starting your short case, there would be a summary. I would say a short summary that would be given to you by one of the representative from the organizing hospital where your examination will be held. And in the summary, you will be getting the clinical vignette and also some relevant clinical findings as well as lab investigations. But yes, your time would be started when the cheat would be given to you, and there would be around 15 minutes or so time for you to go through the case specific, the scenario based focused assessment, and you have to also prepare the suggested questions or the upcoming questions by the examiner. You have to prepare from your side beforehand, so that when the examiner would be asking, you should not be a little bit of surprised, or you should not take much of your time to frame your answer or articulate your answers. Now, a 62-year-old male, as it is already I have shared with you, with a history of hypertension, diabetes mellitus, and chronic back pain, presents to the emergency department with generalized weakness, nausea, and decreased urine output for the past 2 days. Later on, he was shifted to MICU today. Now, the significant clinical findings: BP 140 by 80 millimeter mercury, heart rate of 88 per minute, temperature 37 degrees centigrade, and respiratory rate of 18 per minute. No signs of volume overload. There is no peripheral edema or pulmonary crackles. The serum creatinine is 2.5 milligram per deciliter. The baseline creatinine was 1 milligram per deciliter 2 weeks ago. Now BUN 52 milligram per deciliter. Urine output in the last 24 hours is only 350 ml. I hope you all have gone through the case summary and the relevant clinical findings with some or other the relevant lab investigations. How exam will proceed? During the exam, the candidate is expected to perform a focused, rapid, and structured bedside examination relevant to the question mark in this patient. Can anybody just tell me what is the suggested, or I would say most probable, the short case for which the examiner would be now asking the questions? You post, then I would be answering. Yeah, just 1 second. I have to see, because it is okay. Okay, everybody is thinking it would be more or less specifically aimed at AKI, urosepsis, AKI, abdominal aneurysm. Perfect. You think about and you post. I want everyone to share their viewpoints, because this is something which you are going to receive in your examination maybe 15 days after. So there is no ifs and buts. There is no like, no, yes, I will think about it. Maybe on that day I will be thinking. No, this would be the similar case that would be given to you. Okay, perfect. Now the examiner, if I am the examiner and I am right now coming to you, you have already received 15 minutes of your time, you have already seen the patient, you have already examined the patient, or I would be also standing at the bedside and I would be looking at you, how you are actually going to assess this patient, keeping in view the clinical vignette and the suggested or relevant clinical investigations, clinical findings and investigations. So the examiner will be assessing the clinical reasoning, bedside skills, and real time decision making with your articulation skills and confidence. So if I am the examiner, I would be looking at all these things, and based on that, I would be marking you. Okay, what is the primary working diagnosis here? Definitely all of you have already answered, but I want the complete diagnosis. Maybe that you all will be answering in the real exam, not asking again. It's a case of acute kidney injury in an elderly hypertensive diabetic male with chronic back pain. This is, I think, everybody will agree with me that yes, we are dealing with a case of acute kidney injury in an elderly hypertensive diabetic male with chronic back pain. Now, coming to the examination part, in 15 minutes, I am the examiner. Now, instead of sitting in the examination or like no my chamber in the organizing hospital, I would be coming to the bed side and I am looking at you how you are actually performing your examination for this patient, and the 15 minutes time slot has been already informed by the chief examiner. Okay, so this is something I am actually right now giving you clue, or rather I would say that you should be approaching this case in your real exam in this format, or if the examiner would be asking you also later on, you can actually formulate your answers based on the response that I am actually right now sharing with you. This is something which would be really helpful to you, not for your exam also, but for your day-to-day clinical, the like no improving your clinical acumen, I can say, or like no at the bedside you are like no improving or fine tuning your clinical skills. So the first one would be initial rapid assessment in ICU in critical care. We normally have always in a very much like no mnemonic pattern. So A, B, C, D, E, A, B, C. So many things they have their protocol in the format of A, B, C. So also in this patient, I am also giving you a clue that you should be rapidly assessing this patient in the format A, B, C, D, E. Now, again, as it would be a short case focused in the AKI part. So definitely the second thing would be focused systemic examination for AKI in ICU. So these two things I would be definitely doing. So as an examiner, when I am standing beside the bed and looking at you, folding my hands, definitely I would be looking at how like confidently you are doing both A and B. Clear? Now coming to the A part, initial rapid assessment ABCDE approach, I would begin with definitely as an I am right now acting like I am the examinee. I am just like you. Okay. Now I am not the examiner. I am the examinee. So I would be begin with hand hygiene, right? Introducing myself to the, if the patient is conscious oriented, definitely I would be introducing myself. Yes, I am Dr. XYZ. If the patient is intubated, definitely I would be also like introducing myself to the nurse who will be at the bedside, or maybe somebody who is there at the bedside, some of the family relative is there, then I have to introduce myself. I have to take consent if it is like being seen by or observed by the examiner. Definitely he would be taking all these points in his or her like the assessment sheet. So if the patient conscious and also unconscious, in unconscious patient, how you will be taking consent, you will be at least trying to say to the patient who is intubated or drowsy that myself Dr. XYZ, I want to examine you for like next 5 to 10 minutes. Kindly give permission to me. This is for the sake of my examination which is being conducted today. So this would be short and precise. I am not saying that you have to create a grammatical like no so many things and like no make it very impressive. No, but a one liner would be really impressive for like no the examiner to like no be starting with. You are actually going for a cover drive 4. Okay, and also you can get permission from the bedside nurse. Now simultaneously, the examiner, if the examiner is standing there and he or she is right now have already like gone through the case, and they would be straightforward coming to the bedside and starting the examination or like the history taking whatever, and they will be expecting you to communicate with them. So you can also simultaneously assess while communicating findings to the examiner. It can happen, it may not happen. So depending upon the situation, you can actually make your presence felt there. Now, now coming to the ABCDE approach perfectly, I would be starting A for airway. So my focus is not again airway breathing circulation. Rather, when I know about the clinical summary, the clinical vignette, I have the focused clinical diagnosis in my patient, in the exact patient, that is AKI in an elderly hypertensive diabetic with back pain. So definitely the A would be focusing on assessing patency and signs of impending airway compromise, keeping in view that uremic encephalopathy. If my patient is going in or in uremic encephalopathy, definitely my patient will not be fully alert. So that is the purpose of keeping A airway to start with. Now coming to the breathing part, I have to look the accessory muscles, whether like no use of accessory muscles is right now there. The patient is in like no increased respiratory effort, that would be suggesting metabolic acidosis. So it's not like I'm going into a very much like no structured template just to show I know about ABC. No, for my patient it has to be applied. So I'm trying to make it very clear. It should not like no look very monotonous to the examiner that you are repeating A for airway, B for circulation, B for breathing, C for circulation. No, it would be particular to your patient what you are trying to elicit by this ABCDE. Now for the auscultate part, definitely, if the patient is in AKI, urine output is 350 ml in the previous like the 24 hours. Definitely, patient may be in pulmonary congestion or volume overload. So I would be auscultating and getting the pulmonary congestion and volume overload features by crackles. If the patient is having pulmonary effusion, definitely there would be absent or less breath sounds. Now, coming to the bedside monitors or the lab investigation, that would be like pasted in the nursing chart or the medication chart. So definitely SpO2 would give me idea that this patient is definitely requiring more oxygen, and ABG is showing metabolic acidosis. So in severe AKI, patient may be having Kusamal breathing. Clear? So these are like known rocket science. You do every day this type of thing. I'm just trying to like make it very comprehensive for you to have a structured idea how you have to approach. Now, C for again, if the patient is having hypotension, definitely pre-renal AKI. That could be due to sepsis. Somebody has already posted patient may be in having pyelonephritis or urosepsis. Patient may be very much fluid dehydrated. That could be also pre-renal AKI. So those things would be making my patient hypotensive. Now, patient may be having hypertension also. 140 by 80. Previously, patient was having 110 by 60. So maybe patient now going into hypertension could be chronic kidney disease, acute on chronic disease, or maybe patient is having volume overload or renovascular disease is right now in my patient. Now, JBP, though we do not preferentially do in our day-to-day bedside critical care patients, but yes, if the patient is conscious, oriented, and from emergency has come to your like no ICU, so if the patient having raised JBP, volume overload, CHF, or cardiac tamponade. Though I don't find my patient to be in cardiac tamponade, but you should be having differential diagnosis of raised JBP. Now, if the JBP is low, definitely my patient could be having dehydration and hemorrhagic shock, which I don't think it is there in my patient. Now, simple bedside test. The examiner may be expecting you to check the capillary refill time. Sometimes when we are like having so much of gadgets and the advanced monitoring, we forget about the capillary refill time. So maybe if we'll be talking about these simple things also at the bedside, that could be also giving you some good impression, and the examiner may find itself that yes, you normally know about this basic the monitoring system, examination system at your the normal routine bed to bedside examination. So if it is delayed more than 2 seconds, definitely patient may be in hypoperfusion. Your the fingers peripheral pulses, weak, thready, hypovolemia, sepsis induced vasodilatation. Now, D for disability. Now, in the disability, definitely GCA score already I have explained. Patient if in altered sensorium, that could be due to uremic encephalopathy, severe metabolic acidosis, or could be due to hypernatremia or hyponatremia, because the patient may not be taking fluid or nutrition, and now in fluid depletion resulting in hypernatremia. Patient may be having asterix, so that could be due to uremic toxicity, and that is one you can say absolute indication for the dialysis. Now, E for exposure. Now, in the exposure, you have to check the skin and the extremities. If I'm just giving you the possibilities, it is not that you will be getting all these things in your this specific patient, but this is something for your knowledge sake. If the patient is having petechiae or purpura, so that could be in the AKI setting, could give hint maybe the patient is having thrombotic microangiopathy or vasculitis. Livedo reticularis, if the examiner may be asking in the proper viva, if you are getting livedo reticularis, what could be the possibility? So it could be cholesterol emboli because of the recent contrast use, and diabetic foot ulcers. This patient is a hypertension diabetic, and now in AKI maybe patient is having some diabetic foot ulcer, that you will be only eliciting if you are actually going for the exposure or E, and that could lead to the sepsis related AKI. So this is the first AKI. Now I would be particular system for AKI. I would be already I have discussed about like raised JBP plus bibasal crepitations. If I am getting flat JBP and tachycardia, so it would be hypovolemia, could be due to prerenal AKI. Now, if my patient is having peripheral edema, sacral edema, so that would be suggesting fluid overload, could be due to ATN or CKD. Now, in some cases, infective endocarditis related embolic AKI could lead to new murmurs. May not be appropriate in our patient, but just remember. Now, coming to the respiratory system, already discussed Kusamal's breathing, crackles, pleuritic chest pain. Why pleuritic chest pain is important? The examiner may wish to know from you that pleuritic chest pain could give you a hint that yes, my patient is in having uremic pleuritis or pericarditis. That is an indication, emergency indication for the dialysis. These are the things that is the focused systemic examination. Now, coming to the abdominal examination, you have to go for palpating the bladder. If it is distended, definitely maybe I am dealing with obstructive uropathy, could be due to BPH, is one elderly male, stone, malignancy, Flank tenderness, as some of you have already suggested, pyelonephritis or maybe obstructive uropathy, urosepsis, renal infarction, hydronephrosis. If my patient is having liver enlargement and ascites, could be due to hepatorenal syndrome causing HRS AKI. Now, neurologic examination already explained, asterisk, ischemic encephalopathy. If the patient has history of seizure, if the nurse at the bedside is saying he had one episode of seizure yesterday night, could be suggesting hyponatremia, hypocalcemia, or severe uremia. Now, altered mental status, worsening azotemia, metabolic encephalopathy. Now, the third point, though already we have discussed in our initial introduction class, that focus may not be appropriate for short cases, but the examiner may be, without asking the other like no AB or the ABCDE, he or she would be interested to know that how you are evaluating this AKI with focus, which is a bedside tool. So I am now like elucidating the important points pertinent to our AKI patient. Now, focus should be actively requested and demonstrated if available. So the examiner may be like just waiting that you are like no just telling about that yes there is a role of focus in my diagnosis part, in my examination part, because nowadays in critical care it is not the stethoscope, or I would say focus is better than the stethoscope. So that's why focus should be actively requested and demonstrated if available. If the examiner is saying no, I don't want, or like at this point of time you don't need to do focus, so you have to forget it. But if somebody is keen on knowing how confident you are doing focus at the bedside, so these are the important things that you can say for this particular patient. Now, IVC collapsibility, volume status assessment, more than 50% hypovolemia, prerenal AKI, IVC distended with minimal respiratory variation, volume overload, CHF, CKD. Now, I should be also knowing something about renal ultrasound. If the bedside nurse is sharing with you the previously done ultrasound, so if you are getting normal size kidney, acute pathology, ATN, AIN, or glomerulonephritis, if it is shrunken, small, CKD, if echogenic kidney with loss of CMD, intrinsic AKI, if your patient is having hydronephrosis in the ultrasound, post-renal AKI, that is could be due to obstruction. Clear? Now, coming to the lung ultrasound in this AKI patient, I would be more keen on knowing that my patient is having B lines, which would be suggesting interstitial edema, volume overload, absent B lines, hypovolemia, which could lead to prerenal AKI. Now, the the next point would be I should be also checking the investigation and the treatment charts. So the everything would be there at the bedside. So you may request the nurse to share some of the records or the medication chart or the medical chart or the notes that previously the patient has been already like right now there is actually at the bedside. Now actively ask for and review the fluid balance chart, because if you are thinking this is AKI related to kidney, so I should be definitely checking, I should be interested to know about the fluid balance chart, adequate hydration versus volume overload, medication chart, is there anything that is going on, because the examiner may be keen to know that you have excluded the nephrotoxic drugs history, so NSAIDs, S inhibitors, ARB, or is there any history of contrast use? Previously patient was has undergone angiography. Now daily lab trends, creatinine progression, hyperkalemia trend, and nursing notes, urine output monitoring, GCS, mental status. This is the D. Now E, what are the investigations you can request? The examiner straightforward would be asking what are the the next investigations that you can request at this point of time. Now actively request and interpret the urine analysis, bedside urine dipstick and microscopy. Now why maybe it is not at this point of time the examiner may not ask, but I am actually summarizing everything related to this case. Urine analysis will give you prerenal AKI, high specific gravity, no cast. ATN, patient will be having muddy brown cast. AIN, that is acute interstitial nephritis, eosinophil WBC cast, glomerulonephritis, RBC cast, proteinuria, UTI sepsis, pus cells, nitrite test positive. Now, is there any role of FENA? The examiner may ask you. So you should know about what is FENA, less than 1%, pre-renal AKI, more than 2%, intrinsic AKI 18. Now, the examiner may ask you what are the limitations of FENA in our patient. So definitely the limitations are it is unreliable in patients on diuretics. So in that case, fractional excretion of urea is preferred. Now, this is also misleading in sepsis, rhabdomyolysis, contrast-induced nephropathy, hepatorenal syndrome, where the FENA remain low despite intrinsic AKI. Because these are something more of like I would say hyperperfusion or pre-renal component is more resulting in the ATN. Clear? Now, I would be also interested to know the hyperkalemia and the acidosis part. Now, in the investigations already discussed, renal ultrasound, and the examiner may ask you, this is a 68-year-old male, and now this patient has gone to AKI. Is there any specific investigations that you are like right now advising or interested to get? Yes, glomerulonephritis workup. In that C3, C4, ANA, ANCA, multiple myeloma, chronic back pain. Try to get this idea. This patient is having chronic back pain, hypertension, diabetic, and AKI. Could be multiple myeloma. So serum protein electrophoresis, urine protein electrophoresis. Then hemolysis related AKI, LDH, haptoglobin. Now, your short case viva, after this everything you have checked at the bedside, discussing with the nurse, examining the patient. Now your short case viva proper starts. I would be now just be little bit quicker because everything I have discussed as an examinee. Now the examiner would be asking the similar questions to the examinee who are like the persons now they will be answering. Now pre-renal, intrinsic AKI, post-renal, everything you know. I'm just giving you, the examiner may ask you what are the key differential in my patient. You all know. I'm just trying to summarize the case for you. Model answers by the candidate. Definition and classification of AKI. What are the classifications you know? Can anybody post in the chat box? This is the questions that would be asked in this case. Yeah, just quick because, okay. Which one is the best one currently used? Okay, good. Okay, everybody knows. So just to know your JCS at this point of time. What is the definition of AKI according to KDIGO criteria? That could be the first question in the real Viva. So answer, AKI is defined increase in serum creatinine by more than equal to 0.3 within 48 hours, more than equal to 1.5 times baseline within 7 days, and urine output less than 0.5 ml per kilogram per hour for 6 hours. This is as per the KDIGO criteria. Everybody knows it. I'm just trying to give you the questions that can come when one case of AKI will be asked in your exam. Now, how would you classify AKI? Straightforward question, favorite question. So you should be answering this pre-renal, intrinsic AKI, post-renal. Now, the examiner may ask you what are the other classifications you know for AKI. Already you have discussed or like posted in the chat box. KDIGO is the most widely used. Remember this. Akin, the specificity about Akin is it focuses on changes within 48 hours. It has both serum creatinine and urine output, both KDIGO and Akin. Now, there is another classification already you have already said, rifle criteria. That is the first ICU classification, but there are a lot of limitations. So that's why now KDIGO is the most preferred one. Now the examiner may ask you, is there any phenotype based AKI classification? So phenotype based, the main what I can say, the explanation for this, it classifies AKI based on the cause or etiology of AKI. Pre-renal, then intrinsic, and post-renal. So the causes we all know. It would be dehydration or sepsis or anything like that. Increasing would be ATN, AIN, and post-renal is the obstructive. Clear? And how will you be differentiating pre-renal, renal, and post-renal? Now, the next question, the examiner may ask you to just like identify the possible cause of AKI. Already I have discussed, but these are the standard questions by the examiner. What features make pre-renal AKI unlikely in this case? In our case, in this case, BP is normal. So it is not having like this patient is not having hypotension or hypovolemia. There is no sign of volume overload or dehydration because there is no edema, no pulmonary crackles. So definitely it is unlikely. Now, coming to the next question, the examiner has certain set of questions in his or her mind. So the step would be history and risk factor, how the candidate is confident to elicit the risk factors and reaching in the diagnosis from the history. So there would be some questions on that basis. What key history questions would you ask in this patient? So I would be asking what about the medication history, any recent history of infections, any autoimmune history, any obstructive symptoms or signs. Clear? So these are the questions that can be straightforward come in your short case if you are getting AKI. Now, this patient has chronic back pain. How is that relevant? That examiner may ask you if the examiner like is also getting a short summary about your case. Now, chronic NSAID use, definitely if the patient is having chronic back pain, he must have used the NSAIDs for a long time. That could lead to NSAID induced AKI via reduced renal perfusion. So that could be pre-renal AKI, or these NSAIDs can also lead to AIN, acute interstitial nephritis. Now, multiple myeloma would be also ruled out because back pain plus AKI. So maybe my patient is having myeloma cast nephropathy. Now, the diagnosis, what are the investigations should you order in your like case of AKI? So a standard format. You should not be taking more than 30 seconds to talk about the standard approach or like investigations battery that you would be ordering. Urine analysis, FENA, serum electrolyte, renal ultrasound, serologic tests if indicated. As I am thinking about maybe cast nephropathy, definitely I should be excluding these. Now, there would be some change in the scenarios to know that you understand some of the other like pathologies also. Now, the examiner may ask you if this patient has undergone coronary angiography 24 hours before AKI, what would be the most likely cause? It would be khaki, contrast associated AKI. Maybe the examiner would be asking you 2-3 questions about how do you differentiate contrast associated AKI from ATN. So straightforward, contrast associated AKI peaks at 48 to 72 hours, but ATN would be more delayed onset. As it is more of pre-renal, so FENA would be less than 1%, while in ATN it is more than 2%. Urine analysis, contrast associated AKI, it would be typically benign, few cast, while ATN, it would be muddy brown cast. How do you prevent contrast associated AKI in high risk patient? Adequate hydration before and after contrast. Use isoosmolar contrast media instead of high osmolar agents. Avoid nephrotoxins and NAC, which is very much controversial, but we all use. Is we considered in contrast associated AKI, same as any AKI. There is no specific indication that yes, in contrast associated AKI, you should be doing dialysis in this specific indication. Now, scenario three, maybe the examiner would be slightly changing little bit. I am just giving you the clinical scenario, not discussing in detail. 58-year-old diabetic male with septic shock secondary to pneumonia was resuscitated in the ICU. Now he was on vasopressor for 24 hours and now has persistent oliguria and rising creatinine level. In the clinical examination and like your lab investigation, BP 100/65, heart rate 96, respiratory rate 22, SpO2 91%. Serum creatinine 3.8, baseline 1.2 a week ago. Urine analysis, granular cast, FeNA is 3.5%. Now lactate is 4.5 millimole per liter. What is the working diagnosis? What I am dealing with? You all can post in the chat box. What would be your working diagnosis? The examiner would be asking. Anything? Okay. So Saki. Okay. So this is something I would not say sepsis induced AKI, but yes, this is intrinsic AKI. Intrinsic AKI. So this is not pre-renal, typical pre-renal because of like so many things. The history is suggestive. Okay. Good. Now the next scenario again is slightly changed. I'm just trying to give you a lot of scenarios. 75-year-old male with history of benign prostatic hyperplasia presents with abdominal distension, anuria for 12 hours and back pain. BP 150 by 90, heart rate 82, respiratory rate 16, creatinine 4.5, baseline 1.3, bladder distension on palpation, bilateral hydronephrosis on ultrasound. What is the clinical diagnosis? Obstructive AKI. Perfect. Any other answers? Obstructive uropathy. Perfect. So these are something which would be definitely helpful if you will be knowing the trend and the clinical clue that is given in the examination, that the cheat that the hospital or the institute that you are actually going to appear in the examination will give. Now, some are other case modification for AKI. This is the last slide. For AKI, the short case one, they may give you AKI in a septic patient with multi-organ dysfunction, AKI in a cirrhotic patient, hepatorenal syndrome. You will get the history of CLD, and the patient is right now with decreased urine output, distended abdomen, and you will get AKI. AKI in a post-surgical patient, hemorrhagic shock, bled in the OT or in the post-operative unit. AKI in ICU patient with high dose diuretic induced nephrotoxicity. So these are something case modification for AKI. Okay. Now I think you have got some idea about the short case, how normally the examination evolves, and you are supposed to answer in the examination. Is it okay? Clear? Did you get the idea? So now let's go to the next case. That is the second case. 68-year-old male with severe community acquired pneumonia and septic shock was admitted to the ICU. He was mechanical ventilated for 10 days and required high dose vasopressors for the hemodynamic support. Now in the ICU, patient was in having prolonged sedation and immobilized. RAS score was -4 to -5 for the first 7 days. Patient had ventilator associated pneumonia requiring prolonged antibiotics, hyperglycemia with intermittent insulin therapy, and now on minimal ventilatory settings and being weaned off. New concern on day 14 of the ICU stay: generalized limb weakness, failure to wean off from the ventilator despite adequate respiratory parameter, diminished deep tendon reflex, no cranial nerve involvement or bulbar dysfunction. What is your working diagnosis? All of you, please post. I need at least 20 responses because this is the short case, very favorite short case for your upcoming examination. Maybe some of you will get this case and they will remember me in your exam. Okay, perfect. So you all are on the target. So the clinical suspicion is patient is having difficulty in weaning, most probably due to ICU acquired weakness with likely critical illness polyneuropathy CIP or critical illness myopathy CIM in an elderly male with severe pneumonia which is recovering. Patient had both CAP and VAP and septic shock which is again recovering. Clear? Now how will you examine? Clinical examination, again I have told you this would be a structure approach. So candidates should perform a targeted neurologic and general examination relevant to the ICU acquired weakness. I'm not talking about that you should be again start the examination by looking at the hair color and then eyes and then the oral cavity. No, it would be more or less structured relevant to the critical illness related weakness. Now, what would be the general examination? Vital signs, heart rate, blood pressure, respiratory rate. Why? Persistent hypotension or dysautonomia, because the patient may be having prolonged the bedridden and having some or other autonomic dysfunction. GCS assessment, alert versus drowsy. Skin and extremities. What will you look in the skin and extremities? Look for the muscle wasting. Patient is in ICU, recovering from the septic shock, day 14, not able to enough. So muscle wasting, contractures, pressure ulcers. Respiratory status. Is the patient feeling weaning due to diaphragm weakness? Patient is having paradoxical breathing, rapid shallow breathing. So these are all which would be indicating that yes, my patient is having ICU acquired weakness or diaphragmatic weakness, and difficult weaning definitely will happen. Now, focused neurologic examination for this patient, I have to exclude the other neuromuscular weakness disorders, and more significant in our critical care setting, the examiner may ask you CIP versus CIM versus GBS versus myasthenia gravis. Clear? Now, what are the things that you will find in the CIP, the CIM, GBS, and myasthenia gravis? Motor weakness, symmetric, distal more than proximal. In CIP, polyneuropathy. In CIM, it would be symmetric but proximal more than distal weakness. GPS, it is ascending paralysis. Myasthenia, it is fluctuating, fatigable. In the morning, it will be better, but as the day progresses, maybe in the evening, in the night, patient will be having more fatigue, and you have to put the patient on proper ventilator, fully ventilated. Reflexes decreased or absent in CIP, but CIM may be normal or decreased. GPS, it would be absent, but in myasthenia, reflexes should be normal. Now, sensory deficits in CIP, it is mild or absent. In CIM, none. In GBS, it would be stalking globe pattern, sensory deficit, and in myasthenia gravis, none. Cranial nerve usually spared, but in GBS, maybe facial weakness would be there, may involve the cranial nerves, right? There would be maybe swallowing difficulty. There would be some amount of bulbar palsy also. And in myasthenia gravis, typical patient may be having diplopia, bulbar weakness. Now coming to the autonomic dysfunction, it is common in CIP, tachycardia, BP, instability, but in the myopathy it would be rare. In GBS it would be common, but in myasthenia it would be rare. So this is something which would be very important for your long case also. How you will be differentiating between the neuromuscular weakness in your critical care unit. Clear? Now, key bedside findings I have already discussed. You can just summarize. That would be suggesting CIP, clear, distal more than proximal. Now, focus finding. The examiner may ask you, because everything nowadays, the examiner is always keen on knowing how confident you are in focus for all the important clinical diagnosis. Now, this would be useful for assessing muscle loss, diaphragm dysfunction, and differentiating ICU acquired subtypes. Now, muscle ultrasound, what you will be doing? Quadriceps, rectus femoris, and diaphragm. And you all know there would be decreased in the muscle thickness, increase in the echogenicity. Maybe you will be getting the cross-sectional area would be decreased of the quadriceps or rectus femoris. That would be suggesting muscle wasting. So interpretation, if your patient is having more atrophy and echogenicity, that would be suggesting worse prognosis. Now, diaphragm ultrasound, I think you know about diaphragmic ultrasound. I think in your theory exam, I think there was a question on the ventilator induced diaphragmatic dysfunction, either this year or the last year. So definitely this can be asked in your practical exam also. You should know something about the diaphragmatic ultrasound. the B mode, and the M mode. Again, I'm not going into detail. So it has diaphragmatic excursion less than 10 millimeter in spontaneous breathing, diaphragm weakness both in CIP and CIM you can get. Now the second important finding for the diaphragmatic ultrasound is diaphragm thickening fraction, DTF, less than 20%, failure to in from the ventilator. It is not able to thicken properly. Now third one would be paradoxical diaphragm movement, which would be again suggesting severe weakness, that suggests your VIDD, that is ventilator induced diaphragmatic dysfunction. Interpretation: high risk of extubation failure if you are getting low DTF and poor excursion. Now, nerve ultrasound sometimes also you can do if you are decrease in the nerve cross-sectional area. So definitely that would suggest axonal degeneration that happens in the critical illness polyneuropathy. And there would be loss of the fascicular pattern also. So this would be the nerve thinning. It would be suggesting severe neuropathy leading to delayed recovery. Now, some of the other investigations to rule out would be electrolyte or metabolic workup if the patient is having persistent weakness. So definitely the first electrolyte you have to check each potassium, phosphate, and also acidosis. Blood glucose and HbA1c. What is the importance in our patient? Persistent hyperemia is a risk factor for ICU neuropathy. Then there would be some investigations you can do also, blood investigation, that is creatinine kinase, LDH, aldolase. These are all elevated mildly in the CIM, right? Now, sepsis markers, you can also exclude sepsis by doing CIP. Actually having diaphragmatic weakness, chronic respiratory acidosis feature would be there in the EBG. So that would be indirectly suggesting that your patient is having diaphragmatic weakness. Now, neuromuscular specific test. After this, last time when I was conducting the exam in my hospital, so the external examiner, again, the same case would be there, like was there in my ICU. And the examiner was very particular about nerve conduction study. So what are the nerve conduction study findings in the CIP and CIM? How we can differentiate? So it would be, you have to tell about these wordings: compound muscle action potential CMAP, sensory nerve action potential SNAP. So it would be all decreased in CIP, but it would be preserved in the myopathy, while the CMAP would be decreased or diminished. EMG, what is the role of EMG? So it would be like in the CIP, reduced motor unit recruitment with axonal loss, but CIM, it would be myopathic potential would be there. As it is muscle involvement, so you will be getting electromyography findings. Now biopsy, sometimes when you do not have any other like investigations which is suggesting, so you should go for muscle biopsy. In CIM, there would be type 2 muscle fiber atrophy without inflammation. But in the neuropathy, there would be no muscle pathology. Now, step 3, summarizing the case for examiner. A concise summary impresses examiner. Now, you may be asked about like the case, that what are the differentiating features, what are the risk factors, when you will be suggesting, then what are the investigations that you should be ordering at the bedside. I have already discussed, but this should be something you should be summarizing in front of the examiner. 68-year-old ICU patient with sepsis, mechanical ventilation, and prolonged immobility, presenting with generalized limb weakness, failure to wean, and absent reflexes. My clinical suspicion is critical illness polyneuropathy, confirmed by EMG and NCS. The risk factors being prolonged ICU stay, sepsis, hyperglycemia, high dose vasopressors, and the differentiating features are this, and definitely there is no clinical sign symptoms of GBS or myasthenia gravis or PIM. Clear? Now, expected bedside questions I have already discussed. I am not going into detail, but just remember the questions that can be asked. What is ICU acquired weakness? I think everybody knows about it. What are the major risk factors for CIP and CIM? Again, sepsis, prolonged mechanical ventilation, vasopressor, hyperglycemia, corticosteroids, and NM blockers. How do you differentiate CIP from CIM clinically? Already I have discussed. Just you can just go through the lines. CIP, distal more than proximal. CIM, proximal more than distal. What clinical signs suggest diaphragm weakness in ICU acquired weakness? Paradoxical breathing, RSBI more than 105, failure to win a ventilator. What are the common causes of difficult winning? The examiner may ask you. This is a very much, I would say, preferred question for the examination point of view. Difficult winning, difficult winning. It can be asked as a short case. It can be asked as part of the long case. So the causes of difficult winning, it can be respiratory, cardiovascular, neuromuscular, metabolic, psychological. Always answer in a structured way. If the examiner is asking you a straightforward question like this, no like haywire, like you are answering left ventricular failure, then you are talking about hypophosphatemia. No, always frame your answers in a very much structured way. Respiratory, weak respiratory muscles, COPD, secretions, airway edema. Cardiovascular, LV failure, occult fluid overload, ischemia, diastolic dysfunction. Neuromuscular, CIN, CIM, residual sedation. Metabolic, electrolyte imbalances, hypophosphatemia, hypokalemia, hypomagnesemia. Then psychological, anxiety, delirium, inadequate motivation. Now, how do you assess a patient with difficult winning? The question may be asked if you are like, the examiner is very keen on knowing how you are approaching a case of difficult winning. So, first of all, clinical examination. This is work of breathing, paradoxical breathing, accessory muscle using. Cardiovascular assessment, you have to check the fluid balance, JBP, echo to rule out any diastolic dysfunction. Neuromuscular function, you will be checking the cuff strength, limb power, ICU acquired weakness. Now, what are the winning parameters that you can do at the bedside? This is a very much, I would say, pet question. This is something like you can tell about RSBI, negative inspiratory force, less than minus 20 centimeter water. Vital capacity less than 10 to 15 ml per kilogram is a poor predictor for the extubation success. Now, what are the key strategies for managing difficult winning? Can anybody just post in the chat box? I'm just like right now summarizing everything. What are the key strategies for managing difficult winning? I want to know how many are with me. Sedation holiday. Yes, very good. You have to answer. Sedation free trial, nutrition, correct dyselectrolytemia. Okay. SBT. Okay. Daily physio. ABCDEF. Very good. Okay. Mobilize. Okay. First and foremost thing, optimize the underlying cause. Fluid balance, electrolyte, infection, cardiac status. Then gradual ventilatory support reduction to from the control to the pressure support ventilation. Either TP trials are not advocated nowadays, but yes, this is something which can be beneficial. Now, neuromuscular training, already you have mentioned about that. Early mobilization and physiotherapy to prevent deconditioning. And sometimes you have to go for little dose of diuretics if the patient is having cardiac failure. Bronchodilators, COPD. Now, what does the NIV has role in winning? Can anybody just post? Is there any role of NIV in winning? COPD. Okay. COPD. Okay. Everybody tells about COPD. Okay. So this is a breeze therapy. So in some patients, like where the patient is having CHF, so you can post extubation, you can put the patient on NIV. COPD definitely. It reduces reintubation rates in hypercapnic respiratory failure. But yes, the limitation is if your airway protection is compromised and high secretion is there, definitely you should not use NIV. Now coming to the investigation and management questions, I've already asked you all these questions just for the sake of your understanding from the examiner point of view. Initially I was just trying to act like an examining. Now I am actually asking you the questions. When does ICU acquired weakness typically recover? Partial recovery in 6 to 12 months, but sometimes it remains long-term disabled. What are the scoring systems for bedside assessment of ICU acquired weakness? This would be again one of the pet question. Scoring systems for the bedside assessment for the ICU acquired weakness and CIP. Motor assessment, MRC. Very good. MRC scoring. Okay. I hope everybody knows about MRC scoring. Hand grip dynamometry. Very good. So this is the Medical Research Council sum score. This is the gold standard bedside test for ICU acquired weakness. Clear? How will you check? The examiner may ask you what is MRC score, what is the total score, what is the maximum score, what would be the score below which you will be suspecting that this patient is in ICU acquired weakness. Now, simple thing, the method of examination, assess bilateral strength in 6 muscle groups: shoulder abduction, elbow flexion, wrist extension, hip flexion, knee extension, ankle dorsiflexion. Each muscle is graded 0 to 5, that we all know. 0 to 5 as per the MRC grading system. Maximum score is 60 because two sides, 6, 6. Okay, 12. If the patient is having 5 in all the muscle groups, right side as well as left side, so it would be 60 and minimum score would be 0. Clear? Now, how will you interpret? More than equal to 48, normal muscle strength. 36 to 47, mild weakness. Less than 36, severe ICU acquired weakness. This is the diagnostic threshold. This can be one of the MCQ also. So just remember, less than 36 is severe ICU acquired weakness. More than equal to 48, normal muscle strength. The strength of this scoring system, it is simple, quick, validated in ICU patients. Limitation, this requires patient cooperation. So if the patient is deeply sedated or paralyzed, definitely you will not able to do. Clear? Now, there are some, the examiner may ask you what are the other scoring systems that you know. One is functional status score for ICU. Just remember, maybe asked if you are going for the distinction marks or honors or gold medal, so maybe they would be definitely asking you. This is used for functional recovery assessment in ICU patients. Not going into detail. So 5 functional activities. Again, total score is 35 total, and strength is tracks functional improvement over time. Previously, 2 days back, it would be 20. Now after 2 days, it would be 25. So you can immediately guess that yes, this patient's functional status is improving. So remember, functional status score for ICU, face ICU. Now there is another score, ICU mobility scale, quick assessment of mobility level in critically ill patients. So this would be tracking rehabilitation progress. Previously, this patient was bedridden to start with. Now the physiotherapist is trying to assist in the mobility. Now this patient is having passive or assisted bed mobility, so it would be 1 to 3. Now slowly gradually this patient is sitting and standing with assistant, 4 to 6, and finally walking with or without support, that is 7 to 10. Clear? So this is ICU mobility scale. Now the fourth one, some of you have posted in the chat box, hand grip dynamometry. So this is a simple bedside objective strength measurement. So measure the grip strength using a handheld dynamometer. So cutoff is grip strength less than 11 kilo for men, less than 7 kilo for women. Suggest ICU acquired weakness. So this is portable, quick, but the patient has to do it. So it requires patient cooperation. Hand grip, dynamometry. 11-7, just remember. And this is the grip, hand grip. Okay. Now, this is something I got from Physiopedia, like common clinical presentation of ICU acquired weakness and what are the diagnostic procedures. Already I have discussed everything. Less than 48, EMG, handheld dynamometry, maximal inspiratory pressure, then clinical presentation again. Minimum 1 week sensation is generally preserved. Then cranial nerve function, autonomic function is usually preserved. Tendon reflexes would be reduced, may have function. Now coming to the management part, last but not the least, the examiner would be expecting how you are actually going for managing this CIP or ICU acquired weakness. So it has to be always supportive and multidisciplinary approach. Early mobilization and physiotherapy, optimize the glucose control, wean up sedation and vasopressors, nutrition support, respiratory support. Maybe this patient, in our patient, maybe you need to do early tracheostomy and gradual ventilator weaning. Avoid any nephrotoxic and myotoxic drugs like aminoglycoside, steroid, and neuromuscular blocker, and regular neurologic assessment, functional scoring, and EMG if needed. Now, there are certain critical thinking questions I can right now share with you. Again, this is for gold medal. Why hyperglycemia worsen ICU acquired weakness? Because if your patient is continuously exposed to high glucose level, so that would be promoting axonal dysfunction and mitochondrial injury in the critical illness polyneuropathy. Now, the same thing would be why your patient who is on high dose vasopressor, people say they are going for ICU acquired weakness more because vasopressors on high dose, so definitely there would be ischemic damage to the vasa nervorum, that is the blood vessels to the nerve. So that would be leading to the distal Now, last one, how you would be differentiating VIDD from CIP. So VIDD is isolated diaphragm weakness, while CIP is global limb weakness. Now, last but not the least, the examiner may ask you, like this patient is improving, 14 days in your ICU, and you are now diagnosed that ICU acquired weakness. So this is something not very much encouraging to disclose in front of the family. Like no ICU occurred. The patient was not having this weakness, but ICU was given this in literal words. So how you are going to counsel the family? Okay, so something you will be always saying, explain the condition. Your loved one has developed ICU related nerve and muscle weakness due to prolonged illness or immobilization. You have to explain that this is common in critical care and this would be affecting the ability to mobilize, move, stand, or even breathe. This is something point number one. Then discuss the recovery and prognosis. You have to be very much realistic. You have to explain that these patients show gradual improvement over weeks to months, and this can take almost 3 to 12 months. Be very practical. Don't hide anything. We are closely monitoring the progress and making sure that we are continuously doing rehabilitation, physiotherapy, conditioning, and all the things. Now, the third one would be address the ventilator weaning. Like as this patient ventilatory, the breathing muscles are weak, definitely we need to do tracheostomy. That would be helping the patient to wean from the ventilator. And the last but not the least, reassure and set expectation. Something like no with physiotherapy, nutrition, medical support, many patients they regain function. You have to be very practical, but some weakness may persist in severe cases. You should not be saying that this patient will be after 12 months completely okay. Okay. So with these two cases, I know it is 1 hour or maybe 5 minutes, 10 minutes. So I hope with this much of approach, in your real exam, you can take 90% marks in the short case. If you are so particular, so much focused, and very much like structured in your answer, so definitely this would be helping you. So at this point of time, after this, any thought process, any feedback? Because I have tried to summarize at least two cases, and believe me, some of you will get at least these two cases for sure. Okay. So should we go for the table vivas? Thank you everybody. So a lot of things are still there. If you want to have 1 minute break, you can have, because again I have fully loaded for next 1.5 hours. So Hardik Pandya is ready to have the last minute slog over batting. Okay, perfect. So if you are okay, should I start? Paritos has raised hand. Tell me, Paritos, what do you want? Are you all okay? Just have maybe sips of water, or like maybe coffee or tea, then we will be starting, because it will be now 1.5 hours for sure. Perfect. Okay. So if everybody is okay, so I should be now starting. Examiner's point of view. Have few doubts. Again, yeah, tell me, Paritos. Post it. What are the doubts? Examiner's point of view related to the cases that we discussed. Okay, we can discuss it. Maybe if it is right now taking time, if you are posting, then I can answer, or else answering question for treatment of cap. Okay, you said broad spectrum. Paritos, I know, I completely understand. These are some of the questions. No, you never know uh, what is the right, what is the wrong. But yes, you have to maybe the examiner expected you have to tell about is it a community acquired pneumonia. Then I have to go for using the standard like no BL-BLI combination with atypical coverage. Plus, if it is severe community acquired pneumonia, I should be using steroid. So maybe okay. You have not covered MRSA in the community acquired pneumonia. Is there any history they have given? Patient was in like no hospital, like no healthcare associated pneumonia, or like previously received antibiotic. Okay. I cannot say like treatment with targocid. No, no, you cannot say like that. But if there is like no, any risk factor for MRSA, maybe the examiner was expecting that you should have like not told about that. Okay. Uncomplicated community acquired pneumonia. How many of us like now have used a ticoplanin to start with? I don't think so. Okay, so this is something I completely agree, Paritos. There is no right, no wrong. So isolated cases we cannot like change the way we practice. But yes, it's a bad day maybe. If the examiner expects MRSA to be started with the uncomplicated community acquired pneumonia with a very much like stable hemodynamics, I don't think God is great only. Okay, we cannot like say anything to the examiner, no. Okay, no problem. So with this, we should be starting. This is something I think we have taken a break. Perfect. 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 Okay. Okay. So should we start? So the first thing that is in my table now is brain death declaration and management of organ donor. Second, breaking bad news, counseling communication, clinical audit, ICU quality indicators, conflict resolution in ICU. All these things I need to finish today. So are you ready? Anyone who wants to have maybe some of the things tomorrow, or we should be all finishing today? But it would be definitely we should be finishing not less than or before 10 o'clock. Okay, today. Perfect. Subhas, you are smart. You didn't give me any chance to say that yes, maybe one or two things we can keep for tomorrow. Okay, perfect. So pay attention to this. If you have told that yes today, so this is really important because these are the things you will be definitely getting. Maybe in the short case you can move from here and there. In the long case you can miss some of the things. But these are the things, the tables that I am going to discuss will be giving you 100% marks. 100% marks. Okay. So let's start with the brain death declaration. Again, topic, mark fetching. Examinees make mistakes, and I strongly recommend that you should be simulating in your units prior to examination. Whatever you say, whatever you do in the real exam, you will be little bit be confused how you are actually presenting. Okay, now everything would be case scenario based. There is no theory. Okay. 40-year-old male was brought to the ICU after a severe traumatic brain injury following a road traffic accident. He was intubated at the scene, brought to the hospital in a GCS of 3, E1, BT, M1, bilaterally dilated, non-reactive people. Very standard question. CT scan done, effacement of the basal cisterns and transtentorial herniation. Clear? Now the patient remains deeply unresponsive 48 hours post-injury despite full supportive care. The ICU team suspects brain death and initiates the formal assessment. This is the case scenario that was given to you in your exam, and from the ICU team you are the person who is going to examine this patient for brain death declaration. Now, in the real exam, the examiner would be expecting that you have to go or maybe demonstrate what you will be doing at the bedside. Okay, I will be just be revising what you normally do. Now, please proceed. Structured Viva. What is brain death? There are certain things I will be also asking you questions and also showing how you should be presenting at the bedside. What is brain death and how does it differ from coma and persistent vegetative state? Anyone? What is brain death? Straight question, straightforward question. What is brain death? Absent brainstem reflexes. Okay. Okay. Brain death is the irreversible cessation of all functions of the entire brain, including the brainstem. It is legally recognized as death. This is the basic difference between brain death, coma, and persistent vegetative state. While coma is a deep unconscious state where brainstem function may still be intact and there is potential for recovery. Now, what do you mean by persistent vegetative state? This occurs when the brainstem functions remain intact, but there is no awareness or cognitive function. Patients may have sleep-wake cycles, spontaneous movements, eye opening, unlike brain dead patients. Clear? So the first question in the brain death, the examiner may ask you, differentiate between brain death, coma, and PBS. Now, common mistakes also I will say. Somebody can be confused brain death with coma and PBS. So there are certain smart answer for extra marks when you will be saying that brain death is a state of complete brainstem failure, as Dr. Gautam has cited, while PBS patients have preserved autonomic function. So differentiation is important for brain death versus PBS. Why? Why the examiner would be very keen on knowing that you are not dealing with PBS? Because this is for ethical and also legal decision making. Brain death is for legal decision making. Now, before starting brain death testing, what conditions must be met? Question. Answers, please. As soon as you answer, then my next slide will be coming. What conditions must be met before starting brain death testing? Okay. Okay, perfect. Good. So that means the examiner is actually expecting that you should know what are the prerequisites for brain death testing. Clear? What are the prerequisites for brain death testing? So before brain death testing, as you have all mentioned, reversible conditions that can mimic brain death must be ruled out. Now the first one is established irreversible brain injury of known cause. In our patient, it was RTA, traumatic brain injury. Now the second point, no confounding factors. In this, hypothermia core temperature has to be more than equal to 36 degree. There should not be any sedative drugs and paralytics effects. So confirm the drug was out with half-life calculations. Shock or severe metabolic derangements like BP more than 100 millimeter mercury, sodium, glucose, pH correction has to be there. There should be no neuromuscular blockade. So these are the confounding factors you have to rule out, and there has to be established irreversible brain injury of known cause. Clear? Now, common mistake when the examinee not mentioning that brain death cannot be declared in patients with drug intoxication, severe metabolic acidosis, or hypothermia. So if your patient is really suspected to have drug intoxication, you should not declare brain death. Clear? So this is something which you should remember. The examiner may try to confuse you. Okay. Severe metabolic acidosis again. Hypothermia. Patient was received from a, I would say, frozen maybe pond or river or a lake, and you are thinking to declare brain death. No, you cannot do. Till the temperature is actually right now above the core temperature is more than 36 degree or so. You have exclude other confounding factors. You have waited significant time so that the drugs that has been the patient has ingested that has washed away. Okay. Now, there are certain smart answers for the extra marks. EEG or somatosensory evoked potentials may be useful if you are suspecting the patient is having drug toxicity or metabolic derangements. In these cases, maybe you should be going for the ancillary tests to support your diagnosis. Now, the next question, how do you confirm brain death clinically? Answers, please. Clinically. Cranial nerve, okay. Apnea test. Okay. Anything that comes to your mind, but yes, it has to be validated. Okay. Clinical examination of brain death is not about apnea test to start with. Clinical examination is a standardized neurologic examination that would be demonstrating irreversible loss of all brainstem reflexes. Clear? Now, these are the bedside brainstem reflexes that you should be uttering in front of the examiner. If you are not able to answer or utter these reflexes, the examiner would be completely furious. Papillary reflex, how you are going to do it? What is the expected brain death finding? Corneal reflex, how you are going to do it? What is the expected brain death finding? Oculocephalic reflex, what is its other name? Whether it is normal in the normal person or not, how you are going to demonstrate at the bedside, what will be the expected brain death finding, oculovestibular reflex, otherwise named as cold caloric test, what you will be doing at the bedside, what are the expected brain death findings, gag reflex, cough reflex, wow, you are going to do gag reflex and cough reflex, and what will be the expected brain death finding. Clear? This would be the clinical examination of brain death. Now, common mistake when you fail to mention that spinal reflexes like triple flexion may persist in brain dead patients. Clear? So you should know. The examiner may ask you. There are certain movements you are getting in your patient, whether this patient is brain dead or not. So spinal reflex may be present. Now, smart answers by you all smart people. Brain death doesn't affect spinal cord activity. Some movements like Lazarus sign may occur due to residual spinal function, but these are not signs of the brain activity. These are the activity from the spinal cord, and that can happen, that can be there in the brain dead patients as well. So these are the smart answers. Now, what is the apnea test and how is it performed? Can anybody tell me? I know it's a little bit lengthy question. Answer. So step 4 is apnea. Step 3 is the clinical examination. Now apnea test. Why you want to do apnea test? The examiner may ask you. This confirms the absence of spontaneous breathing when carbon dioxide levels rise. So this is the normal physiology. When the carbon dioxide level rise, the patient automatically goes for the spontaneous breathing. Now, what are the steps? I know everybody knows it. I'm just summarizing it. Pre-oxygenate for 10 minutes. Disconnect ventilator. Provide passive oxygen. Monitor the chest or abdominal movements for 8 to 10 minutes. Check the ABG. PaCO2 must rise more than 60 or by 20 millimeter above baseline. If no respiratory effort, the test is positive, confirming brain death. Now, there are certain common mistakes the examiner may try to know from you whether you are so confident or not. Stopping the test if hypotension or hypoxia occurs and calling it positive. So if your patient, when you are doing the apnea test, now the BP has fallen to 80 systolic and saturation is 86%, whether you should call that apnea test is positive? No. And what will you do if you are test coming as equivocal or inconclusive? A failed test means the test is inconclusive, not positive. Clear? I hope you are all very much clear in this concept. Now, smart answer. Apnea test should be aborted if your SpO2 drops below 85% or MAP less than 60 millimeter mercury. And in these cases, alternative confirmatory test should be used. It's not that apnea test is not done, then you cannot declare brain dead. Clear? So these are some of the, I would say, clinical snippets that you should be knowing. Now, are confirmatory tests mandatory? Questions? Answers, please. Are confirmatory tests mandatory? No. Anyone who says yes? Okay, perfect. Okay. So confirmatory test and documentation not always needed if clinical criteria are met, required when clinical tests are unreliable, that is in drug intoxication and facial trauma affecting reflex test. When you are unable the oculocephalic oculovestibular test because of this maxillo injury, and you are unable to do this doll's eye reflex and other tests. Now, common confirmatory test. What are the confirmatory tests? Cerebral angiography. You will be getting no cerebral blood flow. EEG, no brain activity. Transcranial Doppler, absent diastolic or reverse flow. Now, common mistake. stating that the EEG is always required for brain death diagnosis. It is only needed in special situation. And some smart answers. Now, different countries have variable protocols. Like UK doesn't mandate confirmatory test, but Japan require additional test before declaration. Clear? Now, final takeaways for high marks, stepwise structured answers. What is the definition? What are the criteria? What are the tests? How will you document? What are the ethics associated with the brain death? Avoid common mistakes. Use global perspectives. Understanding international guidelines can impress examiners. Clear? Now, how do you approach the family for brain death declaration and organ donation? This is again very important. The examiner may expect that you have actually declared brain death and you know how to disclose this, because this is something breaking bad news also. Okay. So you have to know about the legal and ethical aspects, discuss with empathy, use simple language, avoid pulling the plug, all those phrases. Legal death declaration, time of death is, the examiner may ask you, when the second assessment confirms brain death, not ventilator disconnection time. When you have done the second time assessment and you are confirming that yes, this patient is brain dead, so that is the time of death, not when you are disconnecting the ventilator. Discuss organ donation sensitively. Rather, I would be suggesting, and also this is the norm also, you should be, rather you must involve transplant coordinators. You should not be discussing about organ donation in the same setting of brain death declaration. Now, common mistake saying we will stop life support now. No, because brain death is legal death and no further treatment is possible. Okay. Brain death declaration in India. The examiner, as you will be all appearing for DRNB exam, which is an Indian exam. So in India, what are the acts that you should know? So this is THOTA, Transplantation of Human Organs and Tissue Act, THOTA 1994, and there were two amendments, 2014 and 2019. So you should remember this act to 1994. And the Indian Act differs from international protocols in examiner requirements, number of assessments, and mandatory documentation. Can anybody tell me how many examiners are required for brain death declaration in India? Okay, interesting. 2, 4, 5. Somebody has written 5. Dipanshu. Very nice. Group of 4. Okay, simultaneously everybody will come. All the 4 people. 4, 3. Very interesting. So we have only the options remaining are 1 and 6, because 2 has already taken, 3, 4, 5. Anybody? Any taker for 5? Look, this is something you will be definitely getting in your exam. And the number of assessments, 1 or 2 or 3 or 4? 2 assessment. Okay, good. So this is something everybody is clear. Okay, I will be discussing that also. Don't worry. Lot of things are there. So just be patient. Okay. So legal requirements are in India. Confirmatory tests are needed only if clinical criteria cannot be fully assessed. It is Indian law. 4 doctors must independently certify brain death. Who are the 4 doctors? ICU in charge, registered medical practitioner, neurologist or neurosurgeon if they are unavailable in your ICU or in your hospital, intensivist with neurology training, treating physician, government appointed doctor for organ donation cases. You have to involve your NOTO. Okay. Now, 2 independent brain death assessment must be done 6 hours apart. Now, the examiner would be asking again, what is the time of death? Time of second brain death confirmation. What is the form that you need to fill up? Form number 10, that is the brain death certificate, must be filled under THOTA. Now, smart answer, India follows a rigorous process with 4 independent doctors and 2 tests to ensure a robust, legally valid brain death declaration. Now, what are the ethical and family communication considerations? Explain sensitively the things that I have already told, and organ donation discussion must be separate and voluntary. This is in India context. You cannot discuss at the same setting. Organ donation also. Common mistake. This already I have discussed with you. Now key differences. This is in the like one like the table that you can get. Number of examiners 4. In UK, US it is 1 to 2 senior. Number of tests 2 tests 6 hours apart. Here 1 to test 2 tests 6 to 12 are apart. Confirmatory test not mandatory, often required. Time of death second test declaration time. Legal framework THOTA 1994. Organ donation link declaration separate from donation. But in UK, USA, they can just do like no at the same setting only. Clear? I think the questions, everything related to brain death have been discussed in detail. Did it make sense? Now you should be very confident if you are getting. Look, this is the law. If the treating physician is a neurologist or neurosurgeon, I think he can tick it in the both the cases. No, treating physician also, he is the treating physician, admitting consultant, and also neurology or neurologist. Okay, so anyway, your requirement is fulfilled. But in case there is some confusion, there have to be 4 person. He can invite somebody from his team also to be another person. Okay, from the neurology department or neurosurgery department. Okay, clear? Now the second part of our brain death. Now everybody is clear. If they can like no perform in the real exam, you need to do it in your like no unit before the exam, just very systematically. What I have actually explained. It hardly took me 15 minutes discussing everything. In the real exam, they will be also expecting you to discuss everything in 5 to 10 minutes. So if you are very sure, you can answer quickly. Now, how will you manage a case of organ donor rather than I would say brain dead organ donor in your ICU? Again, case 35-year-old male with severe traumatic brain injury following a road traffic accident is admitted to the ICU. Despite all efforts, he meets brain death criteria after 2 examinations performed 6 hours apart by 4 independent examiners as per the THOTA guideline. Clear? The family has agreed to organ donation, and the ICU team now needs to manage the donor to preserve organ function. Clear? Why ICU management of an organ donor is important? Any answers? I request all of you to don't leave the discussion, because anyway, you all are like making me talking for 3 hours continuously. So I should be expecting also some dedication from you. Okay. Dyselectrolytemia, optimal transplanted organ survival, organ function, preserve organ for maximum viability of organ harvesting, preserve organ, endocrine function. Very good. All of the things have been correct. So I'm just trying to summarize. General principles of organ donor management. Look, all my answers are actually in a very much stepwise manner. If you have till now understood, I am using the step or the approach to that particular thing in a stepwise manner, and also the questions are also coming in that way. So this is a two-way process for the examination also, and how you should do at the bedside. Now, brain death leads to progressive physiological instability due to hypothalamic and brainstem control. So, proper management in ICU optimizes organ perfusion, preventing ischemic injury. This would be ensuring maximum number of viable organs for transplantation. It maintains hemodynamic stability, avoiding hypotension, hypoxia, or metabolic dysfunction. If you answer these 3 points, the examiner would not be asking you any further question. I'm giving you guarantee. Now, common mistake, somebody saying brain death is the same as cardiac death. No, because still the circulation is ongoing. It is only the brain death. Okay, so the goal of ICU management in brain dead donors is to maintain multi-organ perfusion, optimizing transplantation outcome. As simple as that. Clear? What are the common cardiovascular changes after brain death and how do you manage them? Questions, answers, please. Hypotension, arrhythmias, okay. You are all like no bubbling with knowledge at this point of time because you recently have appeared your theory exam. You are prepared very well, so I expect that you should be just like no vomit. Don't vomit in your room anyway. This is not affecting my laptop or like my position here, but yes. So step 2 is hemodynamic management. Brain death causes catecholamine surge leading to hypertension first. Remember, it is a bimodal presentation. Hypertension first followed by profound vasodilatation and hypotension when there would be brainstem death. Like no, the medulla and the pons, the blood flow will be less. Arrhythmias and myocardial dysfunction due to catecholamine down, that already you have answered. And how will you manage? Volume resuscitation, crystalloids first, normal saline or ringer lactate, vasopressors and inotropes. In the vasopressors, the first choice is noradrenaline, vasopressin is the second choice. Cardiac dysfunction, dobutamine or milrinone. Your target should be monitoring the MAP more than equal to 65 to maintain adequate organ perfusion. Now, always noradrenaline, never you should say dopamine because these patients are more prone to have arrhythmias. Now, how do you optimize lung function in a brain dead organ donor? Any answers? Lung. First heart, already it is over. Lung. How would you manage? Fluid restriction. Lung protective ventilation. LPV. Okay. Good. Very good. So you all are like ready with your answers. Okay. Pulmonary management. Brain death leads to neurogenic pulmonary edema, atelectasis, ventilator associated pneumonia risk. Your ventilator strategy should be lung protective ventilation, FiO2 less than equal to 40%, recruitment maneuver because these patients are more prone to have atelectasis, and minimize barotrauma. You should not be going for high PEEP because this patient may land up in pneumothorax, and in that case, it would be difficult for you to go for lung harvesting. Okay. Now, oxygenating with FiO2 100, they won't go for over oxygenating. These patients also expect all like you should be very sensitive to like not have Vili. What are the common endocrine disturbances in brain dead donors and how do you manage them? Now, answers should come thick and fast. Thyroid, hyponatremia, BIE, hypothyroid. Okay, very good. Okay, good. Okay, hyperglycemia. Okay, endocrine and metabolic arrangement. Why this happens? Because hypothalamic pituitary axis failure happens, leads to hormonal deficiency. Three things you should say: diabetes insipidus. Mechanism is ADH hormone is actually deficient, leading to polyuria and hypernatremia. Treatment is vasopressin, 1 unit IV bolus, then infusion at 0.5 to 2.4 units per hour. Cortisol deficiency. Why? Adrenal insufficiency due to loss of ACTH from the hypothalamus, pituitary. Treatment IV hydrocortisone 100 milligram IV bolus, then 50 milligram Q6H. Sometimes you can go for solumedrol till 1 gram also. Thyroid dysfunction, T3, T4 deficiency. Again, the ideal replacement is T3, that is IV liothyronine. But yes, if you do not have, you can go for the oral thyroid hormone replacement. Here, the thyroid hormone replacement is not for like the replenishing the thyroid dysfunction or taking care of the thyroid. Rather, it would be helping for the myocardial dysfunction. So, thyroid is actually helping to get better contractility of the heart. Clear? Now, common mistake: overcorrection of sodium too fast agar in DI, if you are actually going for overcorrection, it is like no dangerous. Rather, vasopressin corrects DI while improving the systemic perfusion by reducing vasodilatory shock. Okay, vasopressin is actually preferred in DI. Why is temperature control important in brain dead donors? These are all the things that you should be answering in your exam. Temperature control. Brain dead donor. Bleeding, ICP maintenance, coagulopathy, sepsis. Okay, good. Brain death abolishes thermoregulation, causing hypothermia, and that would be reducing oxygen delivery, worsen metabolic acidosis. And what is the management? Passive warming, active warming. Target temperature should be between 36 to 37 degrees centigrade. The mistake is ignoring temperature control, that would be leading to systemic dysfunction. So you should be always going for like no the warming if necessary. Now, what electrolyte imbalances occur in brain dead donors and how do you correct them? I hope everybody knows about it. The nutritional and electrolyte management, hypernatremia due to DI, hypokalemia due to polyuria, hypocalcemia, hypomagnesemia, that would be affecting the cardiac function. Now the correction approach, sodium correction, aim less than 12 millimole per liter for 24 hours to prevent cerebral edema. Potassium again you have to maintain between 4 to 4.5 for myocardial stability. Magnesium and calcium replacement has to be there to prevent arrhythmias. Now overcorrecting the sodium lead to cerebral edema. So you should always go for slow correction of hypernatremia. When should organ retrieval be planned after brain death certification? Any answers for this question? Okay. Timing and logistics for organ retrieval. Organs must be retrieved as soon as possible. And this should be coordinated by transplant team and NOTO. What is NOTO? National Organ and Tissue Transplant Organization. This is very important. They may ask you all this like no these short names also. What is thota, what is noto, what is soto, all these things. Okay. Now, common mistake they may ask you as an ICU or like a team member, are you responsible for organ retrieval logistics? No. ICU team only stabilizes the donor while noto and the transplant team handle the retrieval. Clear? In India, I have already told what are the things that you should remember. In like no people like no they expect that family consent is not needed, maybe in western countries, but in India, though the patient previously has given the will that yes he wants to be a donor, but till now explicit consent from next of kin is mandatory in India, so you have to involve the family. Clear? So India follows a strict legal framework under THOTA requiring 4 doctors and explicit family consent before organ retrieval. Clear? Now we are over with brain death and management of the organ donor. Clear? So now it is breaking bad news. Should we break the bad news now? We should be all expecting good news from you. Okay. Rather, I would say this is related to the ICU, how to break the bad news. Again, there would be all clinical scenarios and I will be summarizing everything you know because you have all appeared your theory exam successfully cleared. So it would be just a revision scenario. 45-year-old male with severe traumatic brain injury has been declared brain dead. You have to inform to the family. The family is really hopeful and waiting outside to hear some good news from you. Okay, now the examiner would be giving you this type of scenario in your exam, practical exam. Now, how you are going to handle or break the bad news? Always in your exam, have a structured answer approach. So here you can use spikes protocol. So you will say to the examiner, I will be using the spikes protocol, and in that A stands for setting. I will find a quiet place, ensure privacy, have a nurse or a colleague present. P for perception. I would be asking to the family relative, what do you understand about your loved one's condition till now? I, invitation. Would you like me to explain the latest findings? K, knowledge. Use very, I would say, simple language. Now, what will be the language in this patient? The brain controls breathing, heart rate, and all body functions. Now, after repeated test, there is no brain activity because you have already declared brain dead. This means he has passed away even though the ventilator is keeping his body functioning. E, empathy and emotions. Be silent after you explain till now. Allow them to react. Acknowledge emotions. I can see this is very difficult. I am here to answer any questions. Now, S for summary and support. Offer support, bereavement counseling, religious or spiritual help, and you should not be discussing. Rather, it is your transplant coordinator or the team from the NOTO would be discussing the organ donation if appropriate. Finished. So this is something, if you would be discussing or answering in this fashion, the examiner would have anything to ask you again further. Clear? Any questions at this point? No. Okay. Now the second clinical scenario, a 68-year-old female with metastatic cancer and multi-organ failure is deteriorating despite full ICU support. Now you have to discuss with her daughter to transition to the comfort care or palliative care. How would you approach? Can anybody just suggest how would you approach in your exam, real exam? I am the examiner. I have given you this clinical scenario. Anything? EOLC care protocol, end of life care protocol. Okay. Okay, good. So I hope you all know. So I'm just trying to summarize. Now this would be, I would be using the nurse protocol for empathy. So there is a protocol and the mnemonic is N, nurse, the N, name the emotion. I can see that you are very worried. You understand the emotion. Anyone in your position would feel the same. Or respect. You have been making the best decisions for your loved one. S, support. We will ensure she is comfortable and pain free. This is important because you are now going for comfort care. So S for support. E, explore options. We have reached a point where aggressive ICU care is causing suffering rather than helping. Would you like to discuss a more dignified approach with comfort focused care? So that means you are actually exploring the options. You have not decided that you are going for the comfort care. So very good empathy protocol, that is nurse protocol, which is easy to remember. Now, third one, a 55-year-old man with severe COPD has failed multiple extubation attempts. You have to explain the need for prolonged ventilatory support via tracheostomy. That means you have to explain to the family about tracheostomy, how you are going to do it. This is also a very, I would say, commonly asked clinical scenario for breaking bad news or counseling or communication. Now, the structured answer approach, I think we all know. I'm just trying to summarize it quickly. Explain the situation in simple terms, that this patient, your father has been on ventilator for several days, his lungs are weak, and despite whatever we do, it is difficult to remove the breathing tube and he cannot breathe well on his own. Give a rationale for tracheostomy. You can draw a diagram also. A tracheostomy, how it is safer, more comfortable way to provide long-term breathing support, and how it would be helping to reduce the risk of further lung infection, and the patient, your father, would be more awake and comfortable. You also acknowledge the concerns like tracheostomy is not the treatment. So I understand this is a big decision, but we will support you with more information and help you understand what to expect. And finally, Discuss the prognosis and next steps. Don't leave the person in the middle of the way that yes, we'll do the tracheostomy. After that, nobody knows. No. This doesn't mean that he will always need a ventilator. It gives him the best chance for recovery in the prevailing situation while preventing complications. Simple. So these 4 lines, if you would be explaining to your examiner, do you think you will give less than 10 if it is the full mark is 10? Okay. Now, question, the scenario number 4. 40-year-old man admitted with septic shock had a sudden cardiac arrest despite full resuscitation. Now, you have to inform the family about his death, about the cardiac arrest. How we are going to do it? Now, ABCDE framework, I will go with. A for awareness. That means I have some very difficult news to share to start with. Don't just jump and run to the family and say your family, your member, family member is dead. No. B for brief explanation. What happened? What happened? The sudden cardiac arrest, code blue, all these things the family would be hardly understanding. So you have to explain despite our best efforts, his heart stopped suddenly and he did not respond to the resuscitation. Now, C, you have to clearly at that point explain or announce that the patient is no more. I am very sorry, but he has passed away. Then after that, definitely you will expect the family would not be taking it so lightly or casually. So you have to demonstrate empathy and give a period of silence. Pause, allow them to process because you have actually broken bad news. So I cannot imagine how hard this is for you. And finally, after that, explain what happens next. Discuss postmortem formalities, support services, also offer time to see the body. You will be inviting or taking the family members or the person in front of you to the bedside to show that yes, we have done our best. Now the your family member, your beloved member is no more, and the family would be also somehow be convinced that yes, you have given your best attempt by doing the CPR. The CPR cart would be there, the ventilator is still on, all the things. Okay. Now, next scenario, complication. How you are breaking the bad news. A 65-year-old male was intubated, needed a central venous catheter. After the procedure, he developed a pneumothorax requiring chest tube insertion. So you have done everything because you didn't have time to call the family. The patient had pneumothorax after putting the central line, and you have again immediately put the chest tube. Now you have to inform the family that that has happened. Now, I would be using Spikes protocol for this. S setting, find a quiet place again. All the same thing. P for perception. Then you have to explain what happened today. Before I explain, can you tell me what you understand about today's procedure? Is that person aware of the things that we have put the central line and the requirement of central line was this and then something has happened? So you have to know the exact knowledge or awareness this relative has. Otherwise you would be starting with we did the procedure and then we had central the pneumothorax, then the family must have previously got the information, so it would be repeating this thing, or maybe the family would be having less confidence on you that you are a complete new guy who was not known to the family or has not seen the patient also before. I for invitation. Would you like me to explain everything in detail? And then when you observe that yes, this person doesn't know anything, then you have to explain clearly. A for knowledge. And in that you have to explain in very simple language. During the central line insertion, a rare but known complication. This word is very important. A rare but known complication. This is not something which has been done for the first time in my ICU today. No. So this is called as pneumothorax. What do you mean by pneumothorax? Don't leave or use these medical jargons. You have to use pneumothorax and in after that air leakage in the lung that has occurred. Again, you have to give the exact statistical analysis of pneumothorax post central line. This happens in about 1 to 2% of cases despite precautions. We identified it immediately and placed a chest tube to remove the air, and he's stable now. This is something you have to explain to the family, that it's not that we have done something mistake and we have not corrected, or we have not tried to correct or rectify. So we have done all the things necessary post pneumothorax also. Now, after this, you have to be empathetic and emotional. I understand this is distressing. We took immediate steps and he is being monitored closely. E. And finally, summary and support. I am like offering you to answer any questions you have, and we are taking all the precautions as well as the steps that to prevent further complications in our ICU or hospital. Clear? So this is in short spikes protocol. Now the next scenario, something like no, I would say angry family relatives when you are disclosing something. A 35-year-old patient with sepsis suddenly deteriorated and passed away within 2 hours coming to your ICU. The family becomes angry and threatens the staff. Okay, accusing them of negligence. They are saying that your team has done terribly wrong. They have not diagnosed my case properly, and they have done something for which my patient who came here walking and talking, and now you are saying that this patient is no more. So these are the some of the very, I would say, relevant clinical scenarios. The examiner may try to put these type of things, and they would be expecting how you have dealt with this type of similar cases in your training period. So be familiar with these cases. Don't be surprised when you are getting the similar cases in your practical Viva exam. Okay. Now, there is a Lassie method for conflict resolution. Lassie? What is Lassie? L for listen. First, don't argue with the family relatives, because something has happened. They are angry and they are trying to threaten the staff. And they are now saying that you have actually neglected. So allow them to express their emotions without interruption. Be silent. Just like listen to them. Stay calm. Acknowledge their pain. Do not argue or become defensive. This is something the examiner would be expecting from you. Example: I can see how devastated and frustrated you are. This is really a heartbreaking situation. Became like the family relatives. You cannot say, and this is maybe a normal thing for you, but for the patient's family, it is something for them, it is no, the patient is something very close to them. Now, second, Lashy, LA, acknowledge feelings. I can only imagine how hard this is for you. You trusted us with this his care, and I understand that this outcome. Yes, now still for the S, separate facts from emotions. You cannot combine the two. Explain in despite all efforts, his infection was too severe. Otherwise, they will be killing you, family relatives. So you have to say that this patient came with septic shock, vasopressors, you intubated, you have done everything. So you have to mention this also. Too severe, body could not recover. Our team worked tirelessly, but unfortunately, some infections become too overwhelming. So these wordings are very important to impress the examiner. So try to keep all those things. Examiner, if you just Rohit Sharma, cover drive. Okay. Now, S. Now after this, the examiner would now create a problem for you. They would say, after this also the family is behaving really aggressively, and they are trying to beat you or some of your juniors. What will you do? So the next S would be stay safe. If aggression escalates, you have to immediately call your security, hospital administration, staff for de-escalation, and keep a safe distance, but remain professional. Don't get to the mob and try to handle that on your own. You have to have a team. Your hospital representation has to be there. Now, immediately they would be like threatening you, we will be like killing you, we will be murdering you, something like that. So inform about next step, like offer post-mortem or case review if the family insists on explanations, and end with support. Sometimes trying to be sympathetic toward their problem also will make them realize that yes, this doctor is understanding, he's also, or he or she is emotional also, and he also feels that this is something happened very unfortunately. So something we need to go in a very systematic approach, Lassie. Now, the next one is again how to explain after cardiac arrest everything you have done, but there is no brainstem reflex, and you have to explain how you are going to do for the brain death declaration. Already explained, so I'm not going to detail, but these are something which you need to know. Explain the situation clearly, what has happened. Explain the prognosis that despite 72 hours of treatment, he has not shown any signs of waking up. This is very important, and you have done all brainstem reflexes testing that suggest very little chance of meaningful recovery. And then you have to offer support, acknowledge the emotions that I understand this is difficult news. Many families hope for recovery, and we always give every possible chance. And then if they would be going to the next discussion, definitely you should be going for palliative options to ensure comfort and dignity. Now, again, junior doctor, your team member's error has led to worsening infection. So, your doctor should have given the antibiotic at middle of the night at 12 a.m., but the doctor has not prescribed. The patient has not received one dose of antibiotic. Next day morning, the patient died, and the family had checked the medication chart, and they didn't have the they didn't get the antibiotic that was actually given to the patient. Now they are now demanding answers as you are the ICU head, or you are the in charge, or you are the attending at that time, and your junior doctor has done something which was not expected. Again, so there is a Pearl's framework for medical error. This is a medical error. Definitely, this is something which was no fault from your team. Okay. So P for partnership. That means I want to be completely transparent about what happened. Don't hide anything at this point of time, because they have already seen your medication chart, and this has not been prescribed as well as given by the nurses. E for empathy. I understand how upsetting this must be. I want to assure you we take this very seriously. That means you are authoritative at this point of time. You are taking it very seriously about that this is a medical error. Acknowledgement of the error. An antibiotic dose was delayed, which may have contributed to the worsening of infection. This should not have happened, and we regret this deeply. This has to be there. The examiner would be expecting that you are hiding, or you are actually explaining in a very much politeful way, and you are regretting deeply. So if you are acknowledging the error, then the examiner would be very happy. Now, R for response. How we are going to fix it? We have corrected the issue immediately and escalated care. Our team is monitoring closely to ensure no further errors occur. Now, if the family relative will ask you, the examiner would now tell you that the family member is saying, no, we want a review to be done by the high officials of your hospital, and strict action to be taken against you as the team leader and your junior doctor. So then you have to go for L, legal and institutional follow-up, and you have to explain to the family, yes, we are conducting an internal review and will take steps to prevent this from happening again. And finally, support and solution for the family. I assure you that this will be formally reported and addressed. Offer to discuss with a senior administrator if needed. You have to involve your hospital administrator also. Now, last, I think this is the last scenario for the breaking bad news. Again, how to break the bad news of withdrawal of life sustaining treatment with the family, because you think that continuing treatment for a 74-year-old patient with severe ARDS with MODS on maximum life support is futile. Now, this is again ethical framework for end of life decision. E for E. Try to remember. Now, E for explore understanding. What do you understand about your loved one's condition? T for truth telling. Despite your best efforts, his organs are failing and his condition is not improving. Human connection and empathy. I can see how difficult this is for you. Involve family in shared decision making. The examiner would be expecting you to use this sentence, shared decision making, or this like word. Now, clarify treatment withdrawal process. Don't give all those medical jargons that withdrawal of life sustaining treatment, WSOT, all those things. No, explain that stopping aggressive interventions doesn't mean stopping care. Rather it would be like giving the persons like the comfort care. Address spiritual and cultural beliefs and long term bereavement support. Again, something last, I think this is high grade glioblastoma. Surgery is not an option. Prognosis is poor. So you have to inform the patient and the family. This is again the spike protocol. You can just use it. MRI shows a brain tumor, and I know this is very difficult to hear, and you have to give the options. This is something ECMO. How you are going to discuss about ECMO for a patient with severe myocarditis on maximal inotropes and ventilatory support, but deteriorating. Explain why ECMO is needed. First point, discuss the risk and benefits and set realistic expectations. Don't give hope that if your patient is on ECMO, then definitely he or she is going to improve. No, even with ECMO, recovery is uncertain and we will reassess daily. Finally, address families' questions also. If they want to know what is ECMO, how ECMO acts, all those things, you have to answer them and try to involve a multidisciplinary team. Lot of questions I have created for you. Wow. Okay, this is something related to pregnancy. I thought this pregnancy and pulmonary embolism, amniotic fluid embolism, these are something very interesting for the examiners also. So 34-year-old pregnant woman had cardiac arrest due to amniotic fluid embolism and is now on ECMO and mechanical ventilation with no signs of neurologic recovery. You have to break the news to the family. Approach, acknowledge the complexity, explain the neurologic prognosis, address the pregnancy aspect sensitively because need based on her the mother's condition, and finally discuss family's wish and ethical consideration. So finally, the exam tips for breaking bad news: use a structured communication method, whether it is spikes or ABCD or nurse or pulse or lassie. Speak slowly with high pitch, low pitch, and modulate. Allow silence in between. Acknowledge the emotions and never rush or post decision on the family. Offer realistic hope, but set clear expectations. Involve multidisciplinary teams for complex cases. Maintain eye contact, appropriate tone and body language. Stay calm and professional, even if the family is emotional or aggressive. Offer solutions, follow up plans, institutional support when appropriate, and if family aggression escalates, prioritize your safety and involve security if needed. Anything at this point of time? We are now over with the second one. Do we continue? How many of you have GCS 15 by 15 at this point of time? How is the Josh? Priyojit, tell me. You raised your hand. Okay. I want very high, not high. Okay. So should we continue? Yes. Okay, we'll continue. We'll finish everything. So still we have 45 minutes to go. Okay. So clinical audit scenario again. Everything is on scenario. Straightforward question for your exam. So the examiner, you entered into the examination hall, and the examiner is now asking you or showing you a scenario that you are working as a senior ICU registrar in a tertiary care hospital. The ICU team has noticed a high mortality rate in patients with septic shock. The department head has asked you to conduct a clinical audit on adherence to the surviving sepsis campaign bundle within first 6 hours of sepsis diagnosis. Clear? Now, how would you go for audit for this case? Anyone? I will get some at least 1 minute break. Oh. Anyone who wants to answer this? No one? How will you go for audit for this case? Because high mortality rate in your ICU when the patients have been diagnosed with septic shock. Okay. So first you have to frame one title of the audit. Compliance with the 1 hour and 6 hour sepsis bundle in ICU, a clinical audit. Now, what are the background and rationale? You have to make it very clear. Why you want studies show that adherence, if you are going for the adherence to the sepsis bundle elements in ICU patients diagnosed with sepsis, then the gap, and what are the quality improvement strategies that you can adopt. Now, then you should be having your standard and the criteria of the audit measures. Compare ICU compliance to the surviving sepsis 2021 bundle. Within 1 hour, what are the things you should do? Within 6 hours, what are the things you should do? You should have the standard criteria. What is actually as per the SSC campaign guideline. Now, what is the audit methodology you will be adopting? The design would be either you should go retrospective or you should go prospective observational study. Clear? What are the inclusion criteria? Who will be included in this study? All ICU patients diagnosed with sepsis or septic shock as per the sepsis 3 definition. Exclusion criteria: those who have already received treatment before ICU admission. Sample size has to be minimum 30 to 50 patients over 3 months. Data collection have to be through ICU case records, EMR, or sepsis order set. If you are ordering for sepsis panel, definitely sepsis is in your mind. Now, what will be the results and key findings? You have to check the percentage compliance with each bundle element. How many patients in those 3 months they have been compliant, or your clinicians or the nurses have been compliant with their treatment, or the bundles have been followed up rigorously. And then you have to identify the